All right, we're going to get started. Welcome back, everyone, for day 2 of our I Can CME Canadian Collaborative Conference on Myalgic Encephalomyelitis. Nothing about us without us. As you can see on your screen, we just have a slide up just reminding everyone that we have simultaneous translation available by clicking on the interpretation button at the bottom. We also have translated captions because we have people from all over the world joining us. So if that's helpful, please feel free to turn that on as well. And all of the information that we went over yesterday, if you missed yesterday, is available in your attendee guide and in the conference program. So both of those are available on our website, on the conference page, and you'll probably also see that shared in our chat because we have a fantastic team in the back end who's doing a great job of sharing bios and all of that information that you may need. The reason that we're not taking time to read long bios is because everybody's really brilliant at this conference and it would take us a long time to get through all of the wonderful things that they've done. So instead, we're asking you to read those things, and that gives us a little bit more time to hear from them. Today's theme is reality of comorbidities and impact on ME research. We hope that everyone will learn more about the common comorbidities that exist with ME and how these impact clinical care and research. We hope to inspire our clinicians and our researchers to think about how these can be better integrated into our care plans and our research going forward. And with that, I'd like to welcome our first speaker of the day, our friend and our colleague, Beth Pollock, to turn on her camera and share her screen.
Wonderful. I'm just going to share my screen, set this up really quick.
And Beth is going to give us a great overview that's really going to get us warmed up for the day.
Oh, thank you. Let me share, go on video. Okay.
Perfect.
1 second, one more second. Okay. Hi, everyone, and welcome to my talk on less studied pathologies and on comorbidities within ME/CFS and long COVID and related infection-associated chronic illnesses. I just want to start by thanking Sabrina and all of the conference planners and organizers for organizing this incredible conference with such an important theme today. I have nothing to disclose. So in my talk today, I'm going to introduce this group of infection-associated chronic illnesses, or IACI, and provide an overview. I was asked to just kind of introduce us for the day by briefly discussing their overlaps and beginning with shared onset patterns and risk factors and symptomatology. And then with whatever time I have left, I will start to overview their less studied pathologies as well, including hypermobility and connective tissue disorders, spinal disorders, and reproductive health conditions. This includes discussing prevalence of these pathologies and comorbidities across illnesses, emerging research in our field, our research at MIT, and mechanistic hypotheses as well. My talk will be a mix of synthesizing and highlighting existing research and our research at MIT, and some of this will be pre-publication and includes preliminary findings. And if we have time, I'll also try to talk about our NIH research roadmap work as well. This talk is really a combination of about 4 much longer talks that I give. So I'm going to try to touch base on as many things as possible, but some slides I'll be moving more quickly through and some things I can't really go into depth on, so I'm happy to answer questions in the panel later. And just to introduce myself very briefly, I'm a research scientist at MIT. I lead research on ME/CFS and on the overlaps and shared pathologies among infection-associated chronic illnesses with a focus on understudied pathologies that significantly impact patients. I'm currently collaborating on several different clinical studies on IACI. I serve on 2 different NIH Recover working groups focused on long COVID therapeutics and clinical trial design. And in our lab at MIT, the Tull Research Group, the PI is Mickey Tull. We're an immunoengineering lab studying IACI with a focus on chronic Lyme disease. We have a clinical study. We study mouse models of illness, and we investigate immunological mechanisms of IACI with a sub-focus on sex differences. Okay.
Yeah. Can I just interrupt for a second?
Yes.
Are we, remind me, are we allowed to allow the audience to take screenshots or anything like that, or is this all to be kept confidential?
That is a great question. Some of these you can take screenshots. Some of this is preliminary research. I would say, yes, you can share. Just please note that some of this is preliminary research and yet to be published.
If there's any slides in particular, you can let us know, and the audience will, I'm sure, will respect that. That's no problem.
That's perfect. Thank you so much for asking. Okay, so I was asked by Sabrina and the conference organizers to provide an overview of IACI and their comorbidities, and in doing so, highlight why it is so important to consider this within both research and clinical care for these illnesses. So all of these illnesses have significant rates of comorbidity. Just focusing on ME/CFS, within ME, 12 to 70% have POTS. That said, 90% of adults with ME have reduced cerebral blood flow and a tilt, so you can have autonomic dysfunction without necessarily the tachycardia response in POTS. A meta-analysis revealed 47% diagnostic overlap between fibromyalgia and ME. 7% of ME patients in a study had mast cell activation syndrome, or MCAS, though this is thought to be much higher. I'm going to come back to EDS later, and in long COVID, about half of long COVID patients have ME/CFS across multiple studies, and that's just ME/CFS. I can do that for all of these illnesses, go across all of these illnesses, and you will find high rates of comorbidities across all of them. And illness clusters are not unique to this group of illnesses. They're commonly seen across diseases with shared pathophysiology. So for example, patients with cardiometabolic diseases frequently have multimorbidity, including obesity, type 2 diabetes, and hypertension, and more. And when I think about this group of illnesses, I think about it more as a larger syndrome, where there are subsets and phenotypes across this syndrome, where people have different flavors of it. They have different combinations of these comorbidities. And I'm very interested in understanding the pathways through this syndrome and why certain people develop different groups of these comorbidities and different levels of severity. And it's really important to take a comprehensive look at symptoms that may be understudied in doing this approach. So please don't take a picture of this slide, just because it has a preliminary figure from an upcoming paper. But IACI share many features, pathologies, and symptoms. Subsets of patients across illnesses share onset patterns, both infectious and non-infectious. They share triggers, symptoms, pathologies, and more. It is especially common for more moderate and severe patients to develop multiple conditions simultaneously with a very complex clinical picture and medical background. It is critical to study these complex and severe patients. Shared pathologies that are more commonly studied in IACI include, but are not limited to, neurological, immune, neurocognitive, cardiovascular, mitochondrial, metabolic dysfunctions, and persistent infections, and more. And unfortunately, these overlaps historically really haven't been well incorporated or captured sufficiently in research. I've read the entire history of literature on their comorbidities and tracked it. And severe patients especially have really slipped through the cracks of both research and medicine, which is something that I think about all the time in terms of less studied pathologies. So I'm so glad this is starting to change, in part due to research on long COVID, but understanding why and how these conditions so frequently overlapped, phenotypes across illnesses, shared mechanisms, common disease trajectories. These all have critical implications for how we structure our clinical studies and our clinical trials, as well as our clinical approaches. So I just want to mention that all IACI are understudied, all of them. So when I say less studied pathologies, all pathologies are understudied, just some even more than others. And there are important research gaps that we must fill. All of the pathologies of IACI deserve to be studied. My hope is that we can include and integrate research on the lesser studied aspects of these illnesses into our studies, and that is a core focus of my research. So here are some overlapping symptoms on this slide. In the interest of time, I'm going to move on, but just broad overview, they include fatigue and cognitive dysfunction, chronic widespread pain, sleep issues, orthostatic symptoms, GI symptoms, hypersensitivities, and more things I'm sure many people here can relate to and understand.
Beth?
One key research, yep,
Beth, sorry to
yeah,
interrupt you.
no problem.
Could you go a little bit slower? We just
Yes.
had a few people ask, sorry.
No problem. And I'll try to go slower. There's so much to cover. We'll just get as far as we can. So one key research question we discuss in the lab is how can different types of triggers, including infections and environmental exposures and injury, and often multiple successive triggers, lead to similarly presenting and overlapping illnesses, and how may onset patterns impact illness trajectories, and how we think about and approach research on treatment and recovery. I could spend a very long time on this slide on onset patterns across illnesses, but I want to move forward. So key points are that infection is by far the most commonly reported trigger. I show the prevalence of this in each illness on the slide and can share more about types of infections that are commonly reported later. Though infection can also be non-symptomatic. So self-reports have important limitations. Physical injury is also an important trigger, and some illnesses like fibromyalgia have a higher prevalence of it. Environmental exposures are another very commonly reported trigger. We are studying environmental illness and environmental sensitivities across these illnesses. It's an area of research that I lead, but we'll have to get to that in another talk. It's important to note that it's common for patients to report multiple successive triggers over time with gradual onset. This is an important part of the illness trajectory for many patients. And in terms of risk factors, all IACI disproportionately impact female patients. 63 to 83% of patients across these illnesses, depending on the illness, are female. Notably, males are at higher risk for more severe acute infections for many types of infections, including acute COVID. And females are at higher risk for many types of long-term infection, of long-term illness following infection. Sex differences and immune responses to infection may partially explain this. There is emerging and ongoing research identifying genetic and hereditary risk factors across illnesses. Other shared risk factors include pre-existing conditions, including some of those in this illness group, and a history of infectious illness. Here's a list of less studied pathologies on this side. Those in green are what I will try to get to today in the time that we have. And my approach to the key kind of studying less studied pathologies and key questions can be summarized as: can we predict, can we prevent, and can we non-invasively treat them? I have a longer list of sub-questions underneath that, such as understanding roles in illness severity and illness trajectories and risk factors, but this is really a list of questions that kind of guide my approach to studying less studied pathologies within this group of illnesses. So I'm going to get to my the first less studied pathologies. So connective tissue disorders and hypermobility are very common in IACI, especially in ME/CFS, POTS, and fibromyalgia. This is not the first time that research has documented musculoskeletal conditions in infection-associated chronic illness. For example, new onset musculoskeletal issues have been documented in children following rheumatic heart disease. So the rates of comorbidities are really significant. Between 12 and 19% of ME/CFS may have HEDS. From multiple studies, 50 to 81% of ME/CFS may be hypermobile. In POTS, up to 31% of POTS patients may have HEDS, up to 90% of HEDS and EDS POTS patients, respectively, in studies of EDS clinics may have POTS. Fibromyalgia, association prevalence, so how frequently they occur in a meta-study, was found to be 68 to 90%. So this is a lot. These are really high rates of comorbidity. And it's important to mention that this is far greater than what's found in the general population. It's estimated that only 0.02 to 0.2% of the population may have EDS. Only 3.4% may have symptomatic hypermobility. So when you are seeing comorbidity rates at 90%, there's clearly something very important going on here that is worthy of study and is an important part of pathology. And one key question is the presence of hypermobility, and really the presence of each of the less studied pathologies that we study, is it a defining characteristic of a distinct phenotype or clinical subset shared across IACI? Phenotyping research within these illnesses are finding subsets that look exactly like this IACI grouping. So I go into more detail on this in longer talks, but I just wanted to highlight that important question. So how about long COVID and hypermobility? Generalized joint hypermobility was found to be a risk factor for long COVID in Eccles et al. Study, but we wanted to establish a prevalence of hypermobility in long COVID. So we collaborated with the Mayo Clinic to study their long COVID patients at their long COVID clinic. And what we found was that 27% of Mayo Clinic long COVID patients had generalized joint hypermobility compared to just 10% of controls. There are other findings in this paper, but I think we may have been one of the first to establish the prevalence and not just risk for joint hypermobility in a cohort of long COVID patients, which can inform how we study long COVID. We also found similar findings in our very preliminary analysis. Please don't share this slide, very preliminary analysis of our clinical study at MIT. We're still bringing in participants, but what we found so far is that in both our chronic Lyme cohorts and our long COVID cohorts, there's a greater prevalence of musculoskeletal conditions compared to controls. So hypermobility, is it associated with more severe illness? This is a question I ask of all our less studied pathologies, because it is critical to study risk factors for severity. It's something I hope that our field can study even more in terms of the potential roles of less studied pathologies in developing more severe illness. So the answer is, at least in ME/CFS, yes. So a survey study of people with ME/CFS with and without joint hypermobility found that those with joint hypermobility had more severe symptoms and worse related quality of life. One possible explanation of this is that in a tilt table study, Van Kempen et al., people with ME/CFS with hypermobility had a more significant reduction in cerebral blood flow on the tilt. And this is even if they didn't have POTS. So it was hypothesized that blood vessel laxity leads to greater venous pooling of the blood and less venous return when upright, and therefore greater cerebral hyperperfusion. Though I really wonder about the possible roles of elevated prevalence of spinal conditions in these findings, which leads us to discuss spinal conditions. So spinal conditions in these illnesses may be related to connective tissue disorders because they may stem from ligament and tissue damage. And conditions found within IACI include upper cranial instability, like CCI or AAI, tethered cord syndrome, Chiari malformation, and other structural conditions. It's emerging research, but they are far more common than many people realize, at least in emerging studies. I have prevalence statistics on this slide. In the interest of time, won't talk too much about this, but even in one ME/CFS study without controls, that's important, many of these studies don't have controls, 80% had disc bulging or hernias, 83% had intracranial hypertension, and a very high prevalence have been found in EDS patients and fibromyalgia of spinal conditions. And in terms of clinical care and kind of implications for research, these spinal conditions importantly can result in neuropathy and brainstem and vascular and nerve compression, cord stretch injury, cerebral hypoperfusion. And that's notable because these are pathologies that are commonly found across illness, like neuropathy and hypoperfusion. The symptoms overlap with IACI, including neurological, orthostatic, and cognitive symptoms, fatigue, and pain. And it's important to study the role of brainstem compression and torsion in the brainstem in these spinal conditions. There are case studies showing improvements in ME/CFS patients and fibromyalgia patients following surgery, but results really vary. And it is critical as a field that we develop non-surgical and non-invasive treatments, and that we can also develop ways to predict who is most likely to develop these pathologies and prevent them. I often talk in much more depth about potential mechanistic hypotheses. So what may be contributing to the development of hypermobility in really each less studied pathology that we study. I have a slide here on immune dysfunction and IACI. Each on this slide can contribute to connective tissue breakdown. And in the interest of time, and because I think other people might touch base on this, I'm going to move forward. But there is important emerging research on each of these mechanisms in IACI and how they can contribute to connective tissue breakdown. One of these studies was a proteomics study, Griggs et al., that found immune dysfunction that can lead to connective tissue damage in EDS patients, including complement cascade and pro-inflammatory cytokines, which are on that slide. In ME/CFS, there were elevated cytokines and MMPs, both which can damage connective tissue in the cerebral spinal fluid. And authors hypothesized that spinal instability and spinal obstructions at the craniocervical junction could actually impair CSF movement and production, and therefore lead to these altered pro-inflammatory cytokines and MMPs. And then there's even evidence emerging of inflammatory of immune dysfunction and inflammatory cell invasion in the spinal tissue itself. So in the phylum of HEDS, tethered cord patients, there were important differences in this tissue. HEDS phylum was half as elastic as non-HEDS phylum. There were mast cells and leukocytes, and this kind of inelasticity increased their risk for cord stretch injury, which we just discussed can result in many of the symptoms that overlap with IACI. This is incredibly important research, and I hope we see more like it. So in our lab, we are also studying mechanisms of connective tissue damage in IACI. So persistent infections have been found in multiple studies in ME/CFS and long COVID, such as HHV6 viral microRNA in the brain and spinal cords of ME/CFS, and there's evidence of SARS-CoV-2 persistent infections in long COVID. And when I first joined our lab 4 years ago, one of the first projects that I pitched and ideated and helped develop was this. We asked, could infection itself or immune response to it drive biomechanical changes in connective tissue? And could we build a mouse model for this? So this is a collaborative project that we did with the ULab. It involved many incredible researchers that are on this slide. And we infected C3H mice and Black 6 mice with Borrelia burgdorferi. This is the bacteria found in ticks that causes Lyme disease. And just for context, previously, members of our lab did research that showed C3H mice develop mast cell-mediated atopic dermatitis following infection. So we knew that one of these mice were more likely to develop a mast cell response following infection. So trigger warning on the next few slides, because they will show dissected mice. If you don't want to look at them, please don't. But what do you think happened when we infected these mice with Borrelia burgdorferi? Did they develop hypermobility? Yes, our mice developed hypermobility following infection. So what we saw is that our C3H mice, the ones that develop a mast cell response, developed hypermobile tails. Their tails lose rigidity. Before infection, it was impossible to tie their tails in knots. Afterwards, we could tie them easily in knots, and the knots held. This looks very similar to genetic EDS mouse models, but these are not EDS mice. They have no connective tissue and gene mutations. This is all infection and biological responses to infection. So on the left, you'll see a mouse that's uninfected, its tail is straight, it's not malleable. On the right, you will see a mouse following infection where we can tie their tails in knots. And I just want to recognize our excellent mouse researchers, Qingying and Grace. We also measured tail hypermobility by testing the tensile force of the mouse tails. This is in part inspired by research in hypermobility in people. And what we found was that infected mice required significantly less force to stretch their tails. Their tails were stretchier, they were weaker, and had similarities to what we see in EDS skin. And you can see in this bioluminescent image, and thank you to Kunzan Liu and Grace and Qingying, you can see in this bioluminescent image that infection spread throughout these mice and sometimes spread to their spines. So we also found that flexibility correlates with spinal flexibility in the tail and the spine. So this suggests that the hypermobility isn't localized. This is systemic hypermobility following infection. And we see collagen degradation between the vertebrae of the spines driven by mast cells. So what's next? A key question I have is, are IACI patients with acquired or worsening hypermobility similar to our C3H mice? So do they have a highly inflammatory immune-mediated reaction to infection? And going back to kind of my driving questions, can we predict this in people? And can we prevent it? And can we non-invasively treat it? So one of the next steps will be trying to research possible treatments for infection-induced hypermobility in mice. Here are some of the treatments we will be looking at in our mouse model. I'm now going to talk about another less studied pathology, reproductive health and gynecological conditions in IACI. So I collaborated with PLRC to write the first review of reproductive health impacts of long COVID, and we contextualized these findings by drawing on research evidence of female reproductive health in IACI. And notably, premenopausal women have a higher risk for long COVID and possibly for ME/CFS, which suggests that sex hormones and sex differences in immune responses to infection may play important roles. So there's a lot to talk about here, but I'm going to focus on the menstrual cycle. So half to two-thirds of female ME/CFS patients report increased illness symptoms before menstruation, indicating that it may be very important for us as a field to consider the menstrual cycle when we conduct patient symptom surveys. So where are patients in the menstrual cycle? Women with ME/CFS compared to controls disproportionately report irregular menstrual cycles, amenorrhea, dysmenorrhea, excessive menstrual bleeding, bleeding between periods. Similarly, menstrual cycle irregularities are also common in long COVID patients, including changes to the length of the cycle, the duration, the intensity of menses. In ME/CFS, between a third and 62%. In long COVID, which is very similar to ME/CFS, we see similar prevalence between a third and 62% of patients commonly experience an exacerbation of long COVID symptoms in the days before their menses. And then a recent British study of menstruating long COVID patients, Mabin et al., found that symptom severity of long COVID peaked in the perimenstrual and proliferative phases of the menstrual cycle. So that's fascinating because it means that patients felt better in the luteal phase, and that is when progesterone is higher. So they also found that long COVID is associated with a host of reproductive pathologies that are similar to what we also see in ME/CFS. And there are important clinical care implications here. So should we be considering menstruation in terms of timing of treatments in clinical care? Is this something we should study? And should we be studying and considering hormonal treatments for some IACI patients as part of a more comprehensive treatment approach? These are questions for future research. In the interest of time, I've got to move through, but we found many overlapping reproductive tract conditions across IACI, all elevated compared to controls. What's interesting is that in POTS in particular, menstrual cycle hormones were found to affect hemodynamics, and menstruation is associated with an increase in dizziness, which is an important symptom in POTS, obviously. We discussed research priorities for the field for reproductive health in IACI. And I just want to highlight endometriosis because it is elevated in some IACI. So research suggests between 20 and 36% of ME/CFS patients, female ME/CFS patients report endometriosis, 20% of POTS patients. So that's 2 to 3.5 times general population prevalence. And the average time to diagnosis for endometriosis is 7 to 10 years. So this is really significant. And there's emerging evidence around prevalence of endometriosis in long COVID. But I wanted to talk about this because some research on endometriosis suggests that there's a role for infection in the development of endometrial lesions. So in 2023, a study found Fusobacterium in endometrial tissue of 64% of 79 women with endometriosis and just 7% of controls. So they studied this in a mouse model. And what they found was that Fusobacterium infection led to endometrial lesions. They also found that when you transplant uterine tissue from infected mice infected with Fusobacterium, they then grew endometrial lesions. And the mice with uninfected tissue transplants did not. And then they tried to treat these mice with antibiotics. And the antibiotics reduced the Fusobacterium and the weight of the endometrial lesions in mice. So clearly, studying endometriosis, possibly as an infection-associated chronic illness, is an important area for future research. And this is what we do in our lab. We study reproductive tract pathologies within IACI. I have on the slide, I want to give everyone another trigger warning. Obviously, there's going to be more dissected mice. But on the mice on the left, you see an uninfected mouse with a normal uterus, normal ovaries, normal reproductive tract. And the mouse on the right was infected with Borrelia burgdorferi, the bacteria that causes Lyme disease. And as you can see, it developed severe reproductive tract pathologies, including enlarged, inflamed, and infected uterus and ovaries and reproductive tract. I want to shout out our incredible mouse research team and also this preprint that is led by Paige Hansen that we have up online. And we hypothesized that Borrelia burgdorferi, which causes Lyme disease, increased risk for gynecological disease in mice. And what we found is that only 9 weeks of infection, the bacteria disseminated in the female reproductive tract of the mice, and that this was detectable. We also found differences in gross pathology of these tissues in longer term infection as well. I am going to skip these. We looked into whether this gross pathology in longer term infection was due to age of mice or was due to just duration of infection. Did age play a role, or was it just the infection? And so we infected 15-week-old mice and 1-year mice for the same amount of time. And what we found was that the infected aged mice had worse pathology. So this implicates age in possible immune responses to infection in this mouse model, and it requires a lot more research. We then looked at data, human data in electronic health records. And I just want to mention that in my review with PLRC, we were unable to discuss chronic Lyme in that review. And the reason we were unable to discuss it is there simply was not enough data on reproductive health in chronic Lyme. So this research fills in an important knowledge gap. And what we found, looking across 3 different databases, Truveta, Olivus, FinGen, was that consistent across all 3 was that Lyme disease statistically significantly increases risk for a variety of gynecological disease. This includes increased rates of endometriosis, polyps, heavy menstrual bleeding, painful fibroids, painful periods, and fibroids. So just in summary, what we found that Lyme disease statistically significantly increases risk for a variety of different gynecological diseases. I have so much else to say, but I think we are out of time. So I hope one of the takeaways is that we can start to include less studied pathologies in our research, both in our clinical trials and in our clinical studies. We do this in our research at MIT, also in PLRC when we funded grants. We made sure that all grantees screened for less studied pathology, screened for comorbidities, because it is vital to track these as part of the data that we collect on these illnesses so we can better understand subsets and we can start to develop treatments and understand which treatments are most likely to help which people. And I am wrapping up at 30 minutes. I just want to say thank you this is a references slide. I want to say thank you to the conference organizers again, and I just want to say thank you to everyone that I work with. Research is a team sport. It involves people of many different areas of expertise coming together to collaborate on projects and move it forward. So I want to thank the Tall Research Group listed in alphabetical order, PI Mickey Tall, and the U Lab at MIT, the Slin Lab, Lisa Slin and Anna Gill, Massasna Armstrong Lab, Stephanie Graich, Chris Armstrong, Natalie Thomas, Hannah Olilla, PLRC and the MIT Center for Clinical and Translational Research. These are all groups that we are collaborating with, I'm collaborating with on research on less studied pathologies because it really takes a village. And I just want to thank everyone here because if it wasn't for everybody's collaborative effort, we wouldn't see the progress that we have. And so thank you so much for your allyship and your contributions to research and advocacy. Okay, that's it.
Thank you so much, Beth. That was really chock-a-block full of good stuff. And I think it gives us a nice warm up for the day when we have to think about all of the things that we're going to be talking about today. And we're going to see you again at the panel later on. So we'll hold questions for you till then. But if you see them in the Q&A and you want to answer them, you're more than welcome to do that. I think actually Alain asked you one in our panelist chat. Thank you so much for doing this for us.
Thank you so much.
Set up. I'm just going to remind everybody again, we have a very jam-packed day of amazingly brilliant speakers. Dr. Yellman is another one, and they are typically fast talkers, so I'm going to ask them to slow down a little bit. It's because they're so passionate and they want to cram in so much good information for us, so I want to remind everybody that's the intention of where it comes from, but we do have interpreters who are really trying to keep up with the technical content and doing their best, so Dr. Yellman, if you could just go a little bit slower for me, even if it means we don't get all the way to the end, it would be better because at least we'll really be able to hear what you're sharing with us. And thank you for being with us today.
Pleasure to be here. I will do my best. I may fail a little bit at that. I am a notoriously fast. I have a lot more to cover, so I'll do my best here. Let me get my slides shared for us. Okay. And all right, is everybody seeing everything okay?
Yep, it's perfect.
Okay, so we're going to talk about dysautonomia and connective tissue disorders today. It's a really big topic, but I'm going to try to cover it at least from a 10,000-foot view. I have no financial disclosures that are relevant to what's covered today. And I am with the Bateman Horne Center, which is a nonprofit that is dedicated to clinical care, research, and dissemination of educational resources on myalgic encephalomyelitis, long COVID, ME, infection-associated chronic conditions, and all the related comorbid conditions, including dysautonomia. So today we want to become better acquainted with the definition of dysautonomia and how its application to patients with POTS or orthostatic intolerance, MCAS, or mast cell activation, Ehlers-Danlos syndrome, and myalgic encephalomyelitis may be different than with other dysautonomic conditions. We want to learn the essentials of diagnosis and management of orthostatic intolerance as one manifestation of dysautonomia. We want to recognize the impact of excessive sympathetic autonomic signaling in driving symptoms. In patients with these comorbid conditions in dysautonomia, we want to better understand the role of small fiber polyneuropathy in these conditions, become better acquainted with gastrointestinal dysautonomia mechanisms and symptoms, and begin to appreciate the possible role of neuroanatomical and neurovascular anatomical structures in contributing to this dysfunction. So this is just a brief slide to show that these conditions are often comorbid and cluster together. Dysautonomia is a grander heading for orthostatic intolerance, of which POTS is one subtype. We find that very commonly in patients with hypermobile EDS and other connective tissue disorders or hypermobile spectrum disorders, and as well as very commonly overlapping with mast cell activation syndrome. And of course, those conditions all overlap significantly with myalgic encephalomyelitis. So in fact, we have data from a cross-sectional study that of those with ME that suggests that 15.5% of those patients in fact have joint hypermobility. And we actually have 28% of those patients having joint hypermobility if they meet long COVID ME definitions. In another self-reporting prospective observational study, we have individuals with generalized joint hypermobility who are approximately 30% more likely to experience chronic symptoms after a SARS-CoV-2 infection, with many of those patients going on to meet criteria for ME. So these are all interrelated conditions, and that's how they sort of tie into the dysautonomia we're going to talk about today. So what is dysautonomia? The autonomic nervous system is a system that regulates our generally subconscious or automatic neurological functions and includes management of things like heart rate, blood pressure, digestion, excretion, perspiration, temperature regulation, pupil dilation, circulatory control, and respiratory control. Dysautonomia is a term that we use to describe this dysfunction or failure of the autonomic nervous system to function or respond predictably or reflexively, as would be expected in a healthy individual. And it's estimated that 70 million people worldwide actually suffer from some form of autonomic dysfunction. There are many well-known primary and what we would call secondary dysautonomias. So primary dysautonomias tend to be neurodegenerative disorders with a primary autonomic failure, whereas secondary dysautonomias tend to involve damage to autonomic nervous system fibers, or other structures of the autonomic nervous system from a primary process. So you can see some examples here below, like an amyloid deposition or inflammation from an autoimmune condition like Sjogren's. But there's tons of different conditions here that can cause dysautonomias. And in fact, these are the conditions that were studied when we defined the baseline for what a definition of dysautonomia is. But I think there's some really important clinical considerations that we have to have when it comes to dysautonomia. So, are a patient's dysautonomia symptoms consistent? Are they static? Or are they progressive? Do they wax and wane in symptomatic presentation with symptom-free periods, or are they progressive? I think this is a really important condition because a lot of those primary and secondary dysautonomias are consistent static symptoms that may even progress, right? And that's not the case with everything that causes dysautonomia. So another question is, might it be helpful to clinically consider whether a patient's symptoms of dysautonomia are due to notable damage or failure of autonomic systems, or are their symptoms of dysautonomia actually more reflective of intermittent misbehavior of the autonomic nervous signaling in specific or unpredictable circumstances, but without evidence for consistent or irreversible damage? And I would argue that when we talk about dysautonomia and the populations I just defined, it's more the latter that we're looking at than the former. And I think this is important because, again, the definitions that we've used to measure and quantify dysautonomia may be misapplied in the misbehavior context, and were defined and determined and developed for patients with primary and secondary autonomic failure. So could this autonomic misbehavior be due to abnormal mechanical forces, to intermittent compression on these nerve pathways? Could this misbehavior be due to abnormal metabolic function with reduced metabolic reserves that drive this autonomic misbehavior? Could abnormal immune system function and inflammation drive this autonomic dysfunction? These are questions we're always trying to answer in this population, but I think that some of those, the answer might be yes, that these are things that could be contributing to the misbehavior or dysautonomia we see in ME/CFS. So one of the primary symptoms that we tend to think of commonly with dysautonomia is orthostatic intolerance, which is the development of symptoms in an upright posture that are relieved or partially relieved by reclining or by lying supine. We have lots of tools for measuring this. We look at hours of upright activity, which is the total amount of time spent with your feet on the floor, either sitting or standing in a 24-hour period. And we know that this is a pretty sensitive test for picking up on people that struggle with orthostatic intolerance. Healthy people can spend 14 to 17 hours of upright activity per day. People with other chronic illnesses have a reduction, but can still be anywhere from 10 to 12 hours per day. But those with myalgic encephalomyelitis often fall between 0 and 7 hours of upright activity. We use orthostatic intolerance questionnaires to determine if orthostatic intolerance could be present. These are validated questionnaires that are used in research and are relatively sensitive for picking up on these symptoms. As you can see here, this OIQ questionnaire has a very low score in healthy controls versus a pretty high score in those with ME at 59.2, and even higher for those that have less hours of upright activity. So it correlates with declining hours of upright activity and higher scores. We also have in the literature, you'll see different questionnaires used. The COMPASS 31 is a questionnaire that's been used, as is the Vanderbilt orthostatic symptom scores. And we don't need to go into the details for those, just for you to know that they exist and are used in research to follow orthostatic intolerance. The other common way we like to measure orthostatic intolerance in the clinic is via a 10-minute passive stand, or what is sometimes called by some people a NASA lean test. And this is where we have a patient lay down for 15 minutes to equilibrate to a supine position, and we measure their heart rate and blood pressure in that position twice before we stand them up and lean them against the wall, and again measure that heart rate and blood pressure every minute for up to 10 minutes in this posture. So this is a way to test what upright posture, what challenges that provides physiologically to a patient who might have orthostatic intolerance. During that test, we will often observe physical findings, including finding a lot of acrocyanosis, or kind of blue or purple color that exists in the hands and feet that is often blanching, as you can see in that picture on the right. We think it is vascular in nature and reflective of venous pooling and abnormal hemodynamic behavior during an orthostatic stress. This is an example of a NASA lean test in a 32-year-old woman, and I don't want to belabor it, but you can see that she started with a baseline heart rate of 85 that no one would say was abnormal, and when standing, that quickly rose to 125 beats per minute maximum at 6 minutes. That is a heart rate increase that is 41 beats per minute total. And that meets criteria for what we call POTS, or postural orthostatic tachycardia syndrome. You need to have a heart rate increase of 30 beats per more 30 beats per minute or more without other explanation to define POTS as one version or one description of orthostatic intolerance. But I would also bring attention to what her blood pressure does and look at the difference between the systolic and the diastolic pressures. Here you have 56 millimeters of mercury difference, and by the end of the test, that pulse pressure has narrowed to 13 millimeters of mercury, and that's a really important finding to keep track of as well, and is also reflective of orthostatic intolerance. So real briefly, there's been debate among people who treat dysautonomia about the validity of the passive stand test, about active stand test, compared to what's considered the gold standard, the tilt table test. But these have actually been compared. So the active stand and tilt table have been compared and followed for a change in baseline heart rate values after undergoing these two tests in patients at 5-minute intervals for a total of 30 minutes in 15 POTS patients and 15 healthy controls. The tilt table testing produced a larger change in baseline heart rate actually than the active stand tests. So it is easier to induce symptoms that you can record on a heads-up tilt than it is on the active stand test. They also found that the sensitivity of a 30 beat per minute heart rate increase for the diagnosis of POTS was similar in both of these tests. And the specificity of this testing for a 30 beat per minute heart rate increase for the diagnosis of POTS was actually lower with tilt table testing compared to an active stand test, which is not the same as our passive stand test. It's standing up without leaning on the wall and measuring these vital signs. So these are generally pretty equivalent. In that same study, they used receiver operating characteristic analysis to determine the optimal change in heart rate to discriminate POTS at 10 minutes was an increase of 38 beats per minute with the tilt table testing and only 29 beats per minute in the active stand test. So that one way of interpreting that is the active stand test is perhaps maybe even a little more sensitive at picking up on true dysautonomia or orthostatic intolerance derived from dysautonomia. So the active stand test appears to require less dramatic cardiovascular heart rate changes to reach statistical significance for determining that dysautonomic hemodynamic response. In an active stand test, engagement of the lower extremity skeletal muscle, often by shifting weight or maintaining balance, may actually improve venous return to the heart, reduce preload deficits that actually drive the challenge that causes the heart rate and hemodynamic responses. So in fact, that may be why the active stand test has these sort of lower thresholds for heart rate response. What about the passive stand or NASA lean test versus tilt table? And this has actually been studied in myalgic encephalomyelitis related dysautonomia as well, but specifically in the long COVID-induced ME population. So 80 long COVID patients exhibiting abnormal hemodynamic or dysautonomic responses to upright positioning both underwent heads-up tilt table testing and 10-minute passive stand testing, and they measured systolic blood pressure, diastolic blood pressure, and heart rate changes from that supine or laying down position to upright positioning, and they measured it every minute for 10 minutes. The passive stand test detected no differences in the ability to detect systolic blood pressure changes. Diastolic blood pressure changes were significantly lower in the heads-up tilt test compared to the passive stand test. So the passive stand test is actually a little more sensitive, and people can argue whether that's good or bad. And the maximum heart rate was slightly significantly lower in the heads-up tilt test compared to the passive stand test as well. So again, the passive stand test appears to be maybe just a little more sensitive for detecting symptoms reflective of an orthostatic stress. So I think the take-home message here is that the passive stand or NASA lean testing may be slightly more sensitive for detecting dysautonomic cardiovascular responses compared to heads-up tilt table. And this NASA lean or passive stand testing is widely available. It's easy to perform in office and appears to be a valid way to detect these hemodynamic responses consistent with dysautonomia, especially when access to tilt table testing, which is very restricted, is just not available. It helps us in the clinic start identifying and treating patients. So what is actually, I'm sorry, there's one other thing I wanted to point out, which is this review article here from the American Heart Association, where there was a recommendation that as part of a complete history and physical, orthostatic vital signs in the form of a 10-minute and they mean passive stand tests, should be completed and are sufficient to delineate autonomic dysfunction in many patients with post-acute sequelae of COVID, or in other words, long COVID, myalgic encephalomyelitis. So this is now becoming a recommendation and is considered validated by the American Heart Association as well, against a heads-up tilt. So what about the different definitions we have for the findings on a Nasoline test? There's orthostatic hypotension, there's POTS, there's neurally mediated hypotension, there's orthostatic hypertension. But I would pose the question, do these distinct definitions actually reflect significant different disease processes? And I think the argument is possibly not. In fact, what we have seen in studies that look at blood flow with a heads-up tilt table test is that there is a significant reduction in cerebral blood flow as a core manifestation of orthostatic intolerance in patients with ME. Healthy controls have a reduction of cerebral blood flow of about 7% when upright. Those with ME have a reduction in blood flow between 24 and 27%. And that is true whether or not they meet POTS criteria or orthostatic hypotension criteria, or if they have no change to blood pressure or heart rate with the orthostatic challenge. So what is POTS here, right? This is often referred to as a disease or a syndrome, but I really think it's better defined as an easily measured adaptive response to upright positioning when the initial functions of the autonomic nervous system fail to maintain adequate blood flow to the brain and to the other organs. In POTS specifically, this adaptive response is an increased heart rate that is increasing rapidly with upright positioning so as to increase overall cardiac output, to get more blood flow back to the brain where it needs to be to function as best as you can when you're upright. While this increase in heart rate can be associated with palpitations and a bunch of other symptoms associated with stress hormone release, catecholamine release, the heart rate increase itself is not the pathological process. It's a response to the underlying pathology, which is this disorder in the autonomic nervous system. That's true as well of that narrowing of the pulse pressure that we saw. That appears to be a vascular adaptive response, also to maintain as much blood flow to the brain and other tissues as possible to increase perfusion pressure at the tissue level when dysautonomia challenges arise. As time passes, and this is important, we have observed in patients with dysautonomia that their adaptive responses to orthostatic stress may change. They may burn out. Such patients may go from POTS to a hypertensive response with upright position, or they may lose vital sign response that we can measure. Yet they still have the signs of acrocyanosis on their extremities. They still have a symptomatic response, and they still have decreased cerebral perfusion, and they still have positive high scores in orthostatic questionnaires. So it's just something to think about when we think about misbehavior of the autonomic nervous system and the terms that we use for measuring that and defining it. There are a lot of symptoms of orthostatic intolerance, as you can imagine. Some of those are from the decreased perfusion, as you can see there on the left, and some are the autonomic nervous system's danger response to that physiological stress, and those are there listed on the right, but we don't need to belabor those today. So what do we do to manage orthostatic intolerance? We want to improve perfusion, expand intravascular volume. We want to constrict blood vessels to improve perfusion pressure at those tissues. We want to control very rapid heart rate, and we want to modulate that autonomic nervous system. I am going to go through the rest of this quickly. Just want to cover some basic concepts. It's not meant to be a perfect guide to treatment here. So we do want to increase free water and sodium intake in equivalent ratios to increase the overall volume in the vasculature to improve perfusion. We can do that with oral fluid and salt supplementation, or we can do it with IV fluids. And there are certain situations where IV fluids really help us. That can bypass the GI tract when there are reasons that oral fluids can't be tolerated from GI symptoms. They can use IV fluids to bridge to clinical symptom relief with other therapies that help with dysautonomia that we're about to cover. It can assist with more rapid recovery during post-exertional malaise, but there are some patients who we just can't get around the severity of their symptoms without IV saline. This is just an example of some of the different ways we can supplement free water or sodium intake, but I don't want to sit on this one for too long. What else can we do? We use compression clothing to restore intravascular volume when that volume, especially on the venous side, leaks out into the surrounding soft tissues, especially in dependent areas like the feet or the hands. We want to get that back into the vascular space and get that venous blood returning back to the heart. And compression is a really good way to do that. There was a study done at Vanderbilt looking at various types of compression and people's response to it, whether they did compression on the legs, on the abdomen, or both, or none. And in fact, what you see here is that as you increase the amount of compression from legs to abdomen to full, there is a decrease in heart rate and a reduction in decrease in systolic blood pressure as you add more compression. People who don't tolerate lower extremity compression due to pain may often really benefit still from abdominal compression. And this is just an example of a patient in whom we did nothing other than have her use basic athletic wear for compression. This was a basic NASA lean test without compression, and this is with compression. And you can see the drop in blood pressure, the narrowing of pulse pressure, the heart rate increase. Just adding Under Armour compression clothing stabilized those vital signs significantly and led to symptomatic improvements. So don't forget compression. We use this drug fludrocortisone, which tells the kidney to hold on to fluid and salt to increase intravascular volume quite effectively. We use drugs called midodrine and droxidopa, which both ultimately lead to an increase in norepinephrine that acts on receptors in the blood vessels to cause constriction in the arteries and veins, which we think helps improve perfusion pressures at the level of capillaries. So more exchange of oxygen and nutrients and removal of metabolic waste products as a result. Essentially, what we're doing with these drugs is we're causing peripheral vasoconstriction, which reduces abnormal or exaggerated misbehavior of the vascular system, leading to peripheral vasodilation. We see that with facial flushing. We see that with temperature intolerance and people who don't tolerate hot showers, for example. So we're trying to reduce that abnormal or misbehavior of the vasculature as part of dysautonomia. We use these drugs to support systolic and diastolic blood pressures and improve perfusion pressures at the brain, at the level of the muscles, and even at the level of the GI tissues. And in fact, we'll often see improvements as a result in cognition, in attention and concentration, in muscular fatigability, in ability to stand upright in one place, in gastrointestinal motility due to improved perfusion to that GI tissue, improvements in blood pressure. Despite the fact that these are vasoconstrictive drugs, the reduction in physiological stress you get by improved perfusion often drops the blood pressure, which was responding to physiological stress more than it increases blood pressure just due to vasoconstriction. And there's even this thing called erythromelalgia, painful swelling and redness in the hands and feet that happens in some patients that these drugs are really helpful with. We also use a drug called pyridostigmine, and this is out of the work from David Systrom at Brigham and Women's, when invasive cardiopulmonary exercise testing has shown two specific pathologies that are observed in ME. There is significantly reduced cardiac preload from impaired venous return, and there is impaired oxygen extraction in the tissues. So we have studied what pyridostigmine can do to potentially change those things. So there were patients that were enrolled in a double-blind, placebo-controlled, randomized controlled trial where invasive CPET was performed and subjects were randomized to receive pyridostigmine or not. And then they had repeat cardiopulmonary exercise testing to determine what changed in their exercise tolerance. And those who received pyridostigmine saw improvements in their peak exercise VO2 max, which is their ability to extract oxygen. And it was done so by increasing right ventricular filling pressures or venous return back to the heart, thus leading to better cardiac output and better circulation. So what does pyridostigmine do? Essentially, it increases acetylcholine upstream of the nerves that talk to the blood vessels. So it allows those nerves to then increase norepinephrine. And here you can see where midodrine and droxidopa would act. This is just a little upstream of that. Increasing acetylcholine here helps on that aspect of the autonomic nervous system. So essentially what we're seeing is an increase in venoconstriction and venous preload to the right atrium, which improves that venous pooling in the lower extremities, the acrocyanosis or skin duskiness, and the edema we see. It increases arterial vasoconstriction with increased diastolic and perfusion pressures, and it may actually help reduce peripheral arteriovenous shunting or skipping of the capillaries and improve peripheral oxygen extraction as well, although we still need more studies to confirm it helps in that way. We do use medications to reduce the activity of the sympathetic nervous system, which is over-exaggerated in response to the physiological stressor here. Beta blockers and ivabradine are drugs that we use for that. This is a newer drug that was shown to reduce a lot of the associated sympathetic overdrive symptoms we associate with this physiological stress. But there's always the question about what does exercise do? What is the role of exercise? Can that increase cardiac output? Can it improve cardiovascular tone, right? Physiological decompensation from spending a lot of time in bed, a lack of physical exertion, it does worsen cardiac output. It worsens vascular tone. It worsens OI symptoms. And we know that regular exercise, at least in healthy individuals, or in some patients with dysautonomia, can improve cardiac output because it improves the strength of the squeeze of the stroke volume, and it can improve vascular tone. It can improve optimal blood flow to muscles and tissues. So would we not therefore assume that exercise can improve POTS? And I would say to that, significant caution needs to be taken, right? Just because there is good evidence that exercise in orthostatic intolerance or dysautonomia patients without ME is beneficial, and there is evidence, that doesn't mean that in patients who do have ME, who do have PEM, that exercise is going to be beneficial. And in fact, it's very harmful in those cases, right? Exercise that triggers post-exertional malaise, which can be nearly any exercise that would have a meaningful clinical significance for these patients, can worsen ME symptoms in the short term, can negate physiological benefits that we would otherwise expect with exercise, and can sometimes worsen long-term symptoms and prognosis as well. So it's not outrageous for people to think that exercise has a role here. And in fact, if we can support people through their orthostatic intolerance to a degree that they can exercise without PEM, it does have some benefit, but that's the challenge, and that's really hard to achieve in some patients. So we always have to consider PEM first. And this is just a reminder that studies that suggest exercise is helpful in POTS do not stratify those POTS or dysautonomia patients by those with comorbid disorders like ME, like MCAS, like HEDS. And that's why these studies have such kind of counterintuitive suggestions that we don't always agree with, depending on the patient population we're trying to treat. Sympathetic nervous system hyperreactivity is part of dysautonomia. We see things like an increased startle response, nightmares, panic attacks, emotional lability, muscle fasciculations, insomnia. People express feeling wired but tired, nightmares, frequent nighttime awakenings, sensitivities to medications that are not the pharmacological action of the drug, other sensory sensitivities, and so on. This is part of the dysautonomia response. We use medicines that block alpha receptors and beta receptors of the fight or flight nervous system to calm that down, such as clonidine or prazosin. We use beta blockers, and actually the aforementioned ivabradine can help as well. We sometimes do use benzodiazepines to treat an overreactive sympathetic nervous system. And while these have fallen out of favor in traditional medicine, the fact that they act on the peripheral nervous system and not the central, not just or not only the central nervous system, I think is actually why they can be effective and used safely in this patient population. There's a whole discussion that can be had there, but I won't belabor that today. Vagal maneuvers, especially applying cold to the face and neck, can calm the sympathetic nervous system. Stellate ganglion blocks, which are injections of lidocaine in nearby a stellate ganglion, which is a ganglion of nerves or collection of nerves that control a sympathetic response in someone, can calm down sympathetic overdrive from time to time as well. We're still investigating this and learning more about this procedure. I would like to say that sympathetic overdrive, this dysautonomia response, is often one of the most common causes of sleep disturbance in those with ME, with pain being the second most common cause. So people may not be able to fall asleep, may have nightmares or wake up frequently too early, or have a racing mind or a disruption of the circadian rhythm, all because of that fight or flight overdrive. And in fact, calming the fight or flight overdrive rather than using sedative hypnotics is often effective for improving sleep. It's important to comment on stimulant therapy, which is used a lot in ME and dysautonomia patients. These stimulant therapies can improve brain fog, attention, and other cognitive complaints in ME, but they can alter or worsen sympathetic overdrive or hypervigilance too. So you have to balance those two things in medicine. It's generally best practice to implement these therapies after you've made clinical improvements in symptoms that drive sympathetic overdrive first. This is just a quick reminder to our clinicians that when you struggle to treat dysautonomia symptoms, whether they're those of sympathetic overdrive, those of orthostatic intolerance or POTS, sometimes there's another driving factor too. Sometimes the other aspects of ME/CFS or comorbid conditions can make those symptoms worse. So sometimes you have to treat the mast cell activation, and now you can better treat the dysautonomia. Maybe it was driving it. So we always have to ask the question, who's driving and who's in the passenger seat, and it's different on an individual basis. Small fiber polyneuropathy is something that we need to touch on that may be partially responsible for some of symptoms of dysautonomia. Small fiber nerves are small unmyelinated sensory afferent fibers or thinly myelinated I delta fibers. They are postganglionic. They are sympathetic autonomic axons, and these nerves have very small diameters that innervate most organs and tissues. We know that they have a lot of role in autonomic functioning, including heart rate response to and blood pressure response to Valsalva, to deep breathing, to tilt. They control sweat responses and a lot of gastrointestinal functions as well. And we know that there is a lot of small fiber polyneuropathy being detected in patients with HEDS, with dysautonomia, et cetera. Specifically in the gut, we know it's densely innervated by small fiber nerves, and a loss of these fibers can result in a wide-ranging collection of abdominal and digestive symptoms, including GI dysmotility and the garbage bag term that we use to call irritable bowel syndrome, among diarrhea, constipation, weight loss, post-eating or postprandial nausea and vomiting, etc. Gastrointestinal dysmotility is one of the major symptoms that we see with dysautonomia in patients. There was a study of 129 patients at a tertiary neurogastroenterology clinic looking at delayed gastric emptying and found that there was a significant overlap in those patients for those who meet joint hypermobility syndrome. Another study out of Mayo Clinic looked at hypermobile patients who had abnormal gastric emptying and realized that some of them had delayed gastric emptying and some of them had accelerated gastric emptying. And I think what's really important to think about here is, like we talked about before, the misbehavior of the signaling could be contributing to the changes in motility. And that can be delayed or accelerated, and that can be in the same patient, and those symptoms can wax and wane. As compared to traditional, what we call gastroparesis, which was defined in a diabetic population where the nerves were actually damaged from high blood sugar. In this case, we think these symptoms wax and wane. They change with position. They change through time because it is an abnormal signaling, not a damage to those nerves. What about neuroanatomy? And I'm coming to the end here. I appreciate your patience. So people have implicated craniocervical instability or atlantoaxial instability in driving dysautonomia. This is a manifestation of incompetence or hyperlaxity of the ligamentous and bony elements that support the cervical spine in the craniocervical junction, specifically C0 through C1 and C1 through C2, which leads to increased motion at these sites. CCI is traditionally thought to arise from neck trauma, but may actually arise in patients who are hypermobile due to incompetence or laxity of tissues. And it's postulated that collagen or ligamentous incompetence may also be triggered by or affected by inflammation, like mast cell inflammation. So this can maybe get worse or develop because of the correlation between connective tissue disease and an immune response. This incompetence or laxity leads to an increased mobility or instability that may precipitate deformation of the brainstem or of the upper spinal cord, including the ventral brainstem. We wonder if this irritation of the brainstem and the autonomic fibers that run through it, could this be driving dysautonomia symptoms? Increased mobility and instability can also create traction on the vertebral arteries and alter the ability of cerebrospinal fluid to flow in and out, or venous fluid to flow in and out of the skull. And this pressure may build up and also affect autonomic nerve fibers in an intermittent fashion. What about occult tethered cord? This is an anatomical restriction of the normal movement of the spinal cord with changes in histology in the base of the spinal cord as a result. This pathology is thought to be from forcible flexion or stretching of the spinal cord against the phylum or tip of the base of the spinal cord, causing tissue damage and repair, inflammation, possibly mast cell mediated, and or altered gene expression at that level. So in addition to leading to sensory and motor symptoms that we consider traditional for tethered cords, so things like lower extremity pain and weakness and imbalance, lower back pain, neurological control of the bladder being a problem, in addition to all of that, we wonder if this downward caudal pulling from a tethered cord actually anchors the brainstem or the cerebellar tonsils into a neuroanatomically disadvantageous position. Again, one that is causing irritation on those structures that potentiates symptoms of dysautonomia. And in fact, I have seen patients who have gotten a tethered cord release who also have craniocervical instability. Their dysautonomia symptoms can sometimes improve significantly, sometimes after a tethered cord release. And we think that might be why. Very briefly, there is one other anatomical thing we're starting to pick up on more often now, and that is the idea of idiopathic intracranial hypertension or increased pressure within the confines of the skull. We have increasing recognition that many with dysautonomia and hypermobility have these symptoms. 20% of people with ME and HEDS have had elevated cerebrospinal fluid pressures upon a lumbar puncture. However, 85% of those patients with ME and hypermobility who do not have elevated CFS pressures on a lumbar puncture can still see symptomatic relief, such as diminished headaches, improved fatigue, less brain fog after that lumbar puncture, which involves removal of some of the CSF and some of that pressure, with these symptomatic benefits sometimes lasting for weeks. So they respond as if they had an increased pressure, opening pressure when that lumbar puncture was performed. So we think that the definition of what is considered an increased pressure was maybe defined in a different population, and that those parameters need to be rethought in our patients with connective tissue disease. And this is just to say too that obstructions that cause this pressure buildup can arise from abnormal venous pathology, venous stenosis or narrowing or tortuosity or twisting, as well as other anatomical impingements. And there's a lot of different reasons that could happen. And this is my last slide. And this is just to say there is an area here in the neck where the jugular vein and the internal carotid artery are leaving the skull. It's a very crowded anatomical area that we call the infratemporal fossa. And this is now becoming an area of interest in people with increased intracranial hypertension symptoms as well. You can see there's tons of nerves that run through here. The jugular vein runs here. This is a common place where we see inflammatory responses, where we see bone pressing on these nerves, pressing on this vein and contributing to increased pressure or decreased venous outflow. And we think that this could be responsible for dysautonomia symptoms as well, that the pressure buildup from compression on that jugular vein and even pressure pushing on these nerves can create abnormal behavior of these nerves. And in particular, there's a ganglion here, part of the vagal nerve called the nodose ganglion that runs through this area that we're starting to see can be compressed or irritated. And it's responsible for regulating things like breathing, blood pressure response, heart rate response, and even digestive behavior. So we can appreciate how irritation of these nerves or compression or inflammation around this area might also drive dysautonomia symptoms. So I'm sorry, I had one more slide. I snuck it in here. There are abdominal vascular compression syndromes that include the veins and the arteries as well that can press on nervous structures or lead to pooling of venous blood that can affect nervous system structures as well that may play a role in dysautonomia, but I don't want to get into that any deeper than that for today. So with that, I appreciate your attention. And hope this has been thought-provoking as far as what is dysautonomia, what does that really mean, and where might this be coming from in patients?
Thank you so much. That was a fantastic presentation. And I appreciate that when we ask you to go a little slower, it does take a couple of extra minutes sometimes to get through the content, but I think it was probably a little bit easier. You're getting tons of emojis. And this is really important content for the community, so I really appreciate you doing it. Excellent slides too. Are we allowed to share the slides?
You are, yes.
Okay, perfect. Thank you so much. And you'll be back for the panel?
I will.
Excellent. Lots of questions already shaped up for you. If you see them in the chat, in the Q&A, feel free to start answering them. Ruhi, are you able to turn on your camera?
Yes.
Share your slides?
Hello.
Hello.
Hi.
Welcome.
Okay. Thank you.
Ruhi's going to give us a presentation on the science and art of caregiving in severe ME, a caregiver's perspective.
Shall I share mine?
Yes, please.
Okay, here we go. Okay, thank you. So I'm going to quickly move through. So Sabrina, just pop up anytime you see that I'm going over time,
Okay.
or give me 5 minutes heads up so I can wrap things up.
I can
I'm
do
just
that,
gonna
yep.
say- I would appreciate it because
You want to put your slides on slideshow because we still see the
yeah, no, I'm going to do that right now. And here we go. So I want to thank you so much for this conversation. I know it's a tough one, and I'm going to do acknowledgements quickly, but with my heart. I am on the traditional territories of the Haudenosaunee and the Anishinaabeg people of the First Nations. And I pay deep respects to them, and I honor them by educating myself in their ways of knowing and being, and actively participating in all my relations. And I also want to honor my elders and ancestors, and I embody our ways of knowing in practicing the art and act of seva, which is in the service of humanity with awareness, compassion, kindness, love, and care. And this is a difficult conversation because it's a deeply emotional one. Can you still see my slides, Sabrina?
we sure can.
Okay, all right, because I've lost my slides on my thing. Just 1 second.
Okay.
It's not letting me move.
Can you try the arrows maybe?
Yeah, I did. 1 second.
Or maybe just take them down and put them back up. That sometimes works.
No, it's not letting me move in any way either. Hold on. So I'm gonna stop the share and I'm gonna restart. Is that okay?
Yeah, absolutely.
Okay, here we go. Okay, it's still not allowing me to do that. Is there a reason?
I don't think so. Do you want me to see if I can bring up the slides, or Carrie, if you're there?
Oh, here we go. Oh, I don't know who did that, but I don't know how that happened.
That's you. That's still you.
Yeah,
But I can ask Carrie to bring up the slides in the background just in case we need them.
yeah, I think it would be good because it's still not moving the way I want it to move. Slide control. Never mind. Nope. Still, nope, can't do it. Okay. So
All right, I'll get the slides up or no? It's working now? Great.
okay. ME is a okay, I'm gonna start. Just let me get my focus back on. ME is a dehumanizing and debilitating biomedical condition impacting multiple systems. So majority of the caregiving for those with very severe ME takes place in dark rooms and quiet spaces. The person suffering is not only radically dependent on their caregivers for all activities of daily living, this is feeding and hygiene and toileting, even position changes in our case, but they're even more so because they are counting on us for sustaining their humanity. And this places a profound burden of responsibility on the caregiver that requires grounding in autonomy, responsiveness, empathy, and ongoing emotional and attentive commitment. So it's really important that I give you an overview from my lens where I'm coming from. The care has been actually an integral part of my both professional as well as my personal life as a mother and primary caregiver to our young human with very severe ME, as a healthcare worker, educator, and advocate, and both as an interdisciplinary researcher, scientist, as well as an ethnographer. And my field research for over the past decade has been focused on studying the impact and creating real-world interventions for shift workers and in preteens and teens as related to altered sleep patterns, and mismatched circadian rhythms because of the imposed societal rhythms, which do not go well with our internal rhythms, our internal clocks. So I am going to talk about two field studies today that are related to the skewed sleep and circadian rhythms, because this really has informed and shaped my perspective on the complexity of caregiving in very severe ME, because we were thrown into very severe ME in a very short amount of time. It was within weeks that our child went from moderate to very severe. So it was a completely unknown territory for us. We had no idea like exactly what was going on. So these studies were also integral in terms of letting me adopt the ethics of care framework for both caregiving for very severe ME and for advocacy for care within the siloed medical systems. And so I am going to have a discussion on that. I'm going to formulate as to where I'm going with this. There are going to be a couple of terms that you're going to notice that in my conversation today that are going to pop up, and I really want to address what the meaning is. And because they are also have been, I'm deeply situated in these two terms within my research as well. One is slow violence. This is a term that I co-opted, and it's a major part of my thesis, my work related to sleep and shift work. Slow violence is something that unfolds gradually. It's very slow, it's indirect, and it disperses over time and space. And it's not seen as violence at all because it's embedded in daily routines, and it's absolutely invisible. And this is a term I borrowed from Professor Rob Nixon because he was looking at the impact of environmental deterioration and its invisible trauma on human beings. In his book, Environmentalism, Slow Violence and Environmentalism of the Poor. And it's unlike acute form of violence, which is very immediate. It's highly visible, it's extremely explosive. And examples of slow violence include unregulated shift work and shift schedules that have profound impact on a shift worker's health and well-being, early school times for teens, and invisibility and the needs of those that are suffering from very severe ME and their caregivers. And also, it's really important as we are discussing this to talk about the idea around extractive and exploitive and coercive methodologies that are used in a broader societal structures against the very vulnerable. So meaning in terms, another one I want to talk about is bioderegulation, and that's going to pop up throughout this conversation. And this is malfunctioning of normal biological regulatory processes that maintain the internal balance. This is the homeostasis. And prolonged bioderegulation leads to conditions like, diseases and disorders and chronic conditions. And this example is prevalent within shift workers because their internal rhythms are so misaligned with the external rhythms of society, as well as teens, which we're going to talk about shortly. And ME patients, because they get worse due to progressive disruption and failure of the homeostatic systems, and caregivers, where the demands, especially in very severe ME, are just relentless and without any formal structures of support in place, which ends up leading to the deterioration of caregivers' health. And this is all happening in these invisible spaces. So in this presentation, I want to explore, this is my thesis, this I'm working on right now, is I want to explore how slow violence unfolds in very severe ME and the caregivers, not as a single event, but as a drawn out process that wears the body, care systems, and relationships over time due to both biological deregulation and as social neglect. These are very important things because they are going side by side. These things are happening. And so by looking at the two field studies, I will consider how ethics of care framework is tested under these conditions, where the medical gaze, maternal labor, and social invisibility intersect. So this lens then, I hope, is going to help us see that care then not only becomes a moral responsibility, but also as a quiet form of resistance to both societal inequities as well as bioregulatory breakdown. So the two studies I'm going to discuss is the decade-long shift work self-care study, slow violence of shift work, and the other one that examined what was going on with sleep in teens, because it was their sleep declined significantly, and I wanted to know what was the barriers that they were facing, and those then how they relate to overall in terms of caregiving. How did that relate to caregiving in severe ME for me? So human beings, we know, are complex, and we are dynamic and open systems. We are in continuous flexible connection with the external world, while at the same time separating ourselves from the external influences. This is so we can maintain what is called homeostasis, a steady state. The study, the decade-long study, it explored that if self-regulation in the form of exercise, diet, and shift schedules, and there were other factors I'm not going to talk about right now, that helped mitigate, if it would help mitigate the negative impact on health and well-being due to bioderegulation that was related to shift work. And also looked at the economics and maternal labor of shift workers. And aspects of this has been presented at various national and international conferences. I say aspects because it's a massive study, and it was studying all these different components. And then I got to present all these different components across different conferences and fields. I'm still presenting. So our circadian clock is critical into the maintenance of our overall well-being. It regulates all aspects of our internal rhythms to day and night cycles. So the greater the bioderegulation, the more intricate the interventions that are needed to achieve homeostasis. So it controls everything for when you're going to go to sleep, when you wake up, when you need to eat, when your testosterone is high, and when is the increase in blood pressure and low body temperature, is all controlled by this incredible clock. And each one of us has our own circadian clock. It's very different from another human being. So shift work, when that kind of bioderegulation happens, when your internal systems are completely misaligned, then the symptoms start to manifest as all these things, as tiredness, brain fog, fatigue, increased negativity, and prolonged insomnia in women, and actually irregular periods and painful cramps. There are thermoregulatory issues and inflammation, muscle mass loss, very similar to what we are going to see, what we started noticing in our young human. And prolonged exposure to this level of bioderegulation actually ends up leading to metabolic diseases and cardiovascular diseases and cognitive dysfunction, autoimmune diseases, addiction, mental health, and cancer. So the study it was very complex because it was looking at real world problems, and it wanted real world solutions, and there were a multitude of variables. So it required mixed methods approach, it was combining both qualitative and quantitative methodologies, and non-linear approach, because what I was doing was, at the same time, I was reassessing and readapting as new insights emerged, and as I expanded into other fields, because it required understanding of various different components. And as I got to understand those, the programs and protocols and frameworks also ended up changing. And so it required an approach, an interdisciplinary approach, and I went into sleep and circadian science and chronobiology and sports nutrition, sports science and chrononutrition, occupational health, labor economics, and gender studies. And at this point, I've been studying, when I started this, I was in the field of sleep medicine for already a decade when I initiated this study. And the program, this is a small sample. I'm not going to spend too much time here, but I just wanted to give you an insight, and it'll be available on the slides so you can have a look. So it's a protocol. This is just a 5-year thing, and it was just in terms of work-related aspect to how the protocols I was doing, how it was functioning in terms of productivity, because we value human beings in productivity. So the peaks here represent, I had to take time off from for elite athletic training in order to learn. So this here shows the horizontal bars are actually representing the protocols that I installed or adopted as the time went on. And these all represent in terms of how many sick days I took off and how many unpaid days I took off and where the sick days were. So the study showed that to make any kind of meaningful impact, the symptoms related to night shift work and unregulated shift schedules, that exercise needed to be at an elite athletic level. So that's why I had to take major time off to actually learn athletic training at an elite level, although I was fairly active, but this was a whole another ballgame. And it needed to be timed, very precise on when I was doing night shift work, when I needed to exercise, and on days off when I needed to exercise. And also the controlled timing of type of diet and nutrition, because when you're working night shifts, there is adjustments need to be made because your hormones are completely off. And you need to take that into consideration in terms of like what you should be eating and when you should be eating. And you also have to take into account that also elite athletic training also requires a very precise kind of diet. So it showed that although such adaptive measures behaviors mitigated, but they did not reverse the health risks of chronic sleep deprivation. So you could do all the good diet and elite athletic training, but if your system is chronically dysregulated, that's not going to help. Eventually, it's going to catch up with you because you can't keep on, it's not a sustainable system. And the recommendations are there. I'm not going to go into it, but they are there for you to have a look into it because they do address a lot of different things. So what I learned from this study in context of severe ME was that it's really important to have an understanding of complex bioregulatory systems and how they interact with broader societal structures, and embodied awareness as to when to allow for rest and when to mobilize effort. Because in my case, what ended up happening was I was doing elite training and I was pushing myself, and I got really injured. And I had to take a lot of time off for recovery and then reassess what was going on. So it was really important to understand, back off and when you should be going and when you shouldn't be going, and to be able to reassess and reorganize when new information came. So to be able to pivot very quickly to adapt new strategies as new information emerged, and also to take into account the living realities of healthcare shift workers, because in any shift work case study or any complex studies, we are just doing things in the lab. We're not taking their lived realities into account, and especially mothers who have an other full-time job. They are doing about 30 to 40 hours of domestic labor, which is unpaid labor, and it's not taken into account at all when we are talking about mitigation or making recommendations as to what you should do in terms of your health and well-being. So all of that was taken into account. The second thing I want to talk about is these workshops that I initiated with elementary, high school, and middle school students. And I was beginning to educate them in terms of science, nature, and importance of sleep, because as my child was also entering these things, I thought it was really important to give them an idea of, to be able to empower them about themselves and their health and well-being, so they don't end up having misaligned systems. So I followed a same group of students from elementary school all the way up to high school. And our conversations really deepened as they went from, preteens into teens. And I was noticing that actually only 1 out of 2 per class was actually getting adequate sleep. And I really wanted to know why that was, what was going on. So I initiated a field case study in collaboration with the students and teachers and caregivers to find out what were the barriers and what were the factors that was influencing their sleep, because they were supposed to be getting around 9.5 hours is what's recommended and more. And they were only getting about 7 to 7.5 hours. And that wasn't just a local concern. It's actually a global concern. So it required collaboration. And one of the things that I really wanted to let them know and let us know is that one of the factors is biology, that the biology of adolescent sleep is very different from societal clocks. And the circadian process is completely different. It's delayed. Melatonin is delayed. The clock itself is shifted. And the drive to sleep actually also is altered. It builds up very, very slowly over the day. So they want to go to bed late and they want to wake up late. But early school start times is not conducive. It's incompatible with their internal rhythms. And their barriers were, they have a lot on their plates, especially as universities are recommending that they want more and more. So they have these incredible structured activities that went on and on. And then they have social media and there were environmental disturbances. And some of the kids had to get up very early to catch bus and they had jobs. And then, they are worried and they're on social media and there's overstimulation. All of these factors were involved in some of the barriers. So then you look at when they started sharing what the symptoms were they were experiencing, it was very similar actually to what shift workers were experiencing, which is misaligned sleep and anxiety, depression, cognitive dysfunction, impaired memory and learning problems, and painful periods and frequent headaches. So this was also being reported at the same time because there was a global study that came up around that, and that was showing this is actually what's happening with teens, and that over 90% were not actually getting the sleep that they actually need. So imagine what it's doing to their incredibly amazing brain that is in development. And so teen brain is very different, as we know, from adult brain, and it's in the process of development. So it's extremely vulnerable to any kind of external influence. And that was really an understanding that I needed to know, because when our child became very severe, they were also experiencing, they were also a teenager. So we had to be very mindful of what we needed to do in terms of treatments and medications and such. And also really understanding and respecting, making visible their lived realities, because everybody would say, oh, they're just teenagers or they're lazy and all of that. And then we're like, no, there's something else going on. And we really need to respect that. And to tell them that it's not them, it's the societal systems that are completely incompatible with their lived realities and their health and well-being. And in order to have these really honest conversations, and we needed to create, I needed to create a very safe spaces for them. And these are kids that I have known for a long time. So it was really great to be able to have very honest dialogue with them. So in order to be able to build interventions that were related to their reality, not just some, structured stuff where you say, go to bed at this time and eat good food and exercise. That's not possible. A kid who is coming from a vulnerable and from poverty is not going to be the same that to a kid whose parents have the economics to be able to support all their other needs. So all of that needed to be taken into consideration, and then workshops and ideas were developed around those things that honored their lived experience. So how did these studies help me identify the needs and care for my young human with very severe ME? First was that it was symptom manifestation. Symptom that I was able to identify very quickly what was going on, because we were like, this is not normal. And then once the condition became very severe, to be able to have the environmental controls in place and to really honor that this person is actually going through this incredibly devastating condition, and to have knowledge that there are systemic biases, because my studies indicated that there are structural and systemic inequities. And so that was already placed in my consciousness. And that advocacy is so critical, that it's grounded in not just good biomedical science, but also to be able to distinguish what is good biomedical science and what is not. And to have that interdisciplinary lens is also fairly critical. And that it's grounded in humanity. And that was an incredibly critical part that I'm going to be discussing throughout this. So the symptoms that manifested over a course of a year before we were trying to get a diagnosis, and these things just started popping up, and we would deal with one thing and another thing would come up, and then we would deal with that thing and the other thing would get worse. And it was just and any parent would tell you, an absolute nightmare. But having the knowledge of through shift work case study and through teen case study, I was able to figure out exactly, what the symptoms were, and then to take a back seat for a second and say, okay, what is going on here? And so it's very difficult. And Sabrina and I've discussed this, and I've discussed it with other people too, that navigating silos of healthcare system places an inordinate burden of responsibility on a patient and caregiver. And that's for everyone, because our systems are not connected together. They're just separate in these little bits. But it's especially challenging for those who are suffering from multi-system conditions like ME and their caregivers, because specialists are so focused on narrowly in their own field, which in cases, if you're just looking at a discrete part, it's going to lead to misdiagnosis, which is then going to lead to mistreatment, which then delays the actual diagnosis, which contributes then to symptom severity and emergence of new symptoms. Devastating for caregivers and patients who actually have little to no understanding of the condition itself. So that level of inadequate knowledge then further contributes to mistreatment and mismanagement, and not because of their fault. It's because that information is not made available to them, which has catastrophic consequences on the lives of both the patient and their caregivers. So when the healthcare systems are operating in silos, people with complex chronic illnesses carry a heavy burden. And the strain is even greater for those who are caring for someone with very severe ME. So caregivers must continuously articulate and advocate on behalf of their loved ones who are rendered invisible within clinical discourses. And while they're navigating the impossible terrain of fragmented healthcare systems. And this is in very severe conditions. This is more so because you are doing the articulation for them, because they are not able to communicate, because communication at that point is also influencing their bioenergetic process, because it's all energy. And so you have to be very attuned to their needs and understanding of what's going on. And though we know that the condition requires an interdisciplinary REMS, it's near impossible in systems that are also built to compete and not collaborate. So we use a lot of words about collaboration, but when the system itself is based on meritocracy and it's based on competition, it makes it very difficult for people to actually let go and come together. In most cases, not everywhere.
Just
So-
giving you a heads up, as you asked
Yep.
for, 5 minutes.
Oh, really?
Yep.
Oh, I thought I had 30 minutes.
Yep. You have 5 minutes left.
Oh my gosh. Okay. So we have multidimensional, multifaceted humanistic approach. Definitely non-invasive methodologies, because non-invasive methodologies are critical in terms of very severe cases, because even anything tiny can influence their energy levels and can actually deteriorate, like taking blood sample, for example. So you have to be very mindful about that. And you have to let go of the normal societal expectations of capacity, productivity, and visibility. And this kind of debility needs to be understood, that it's not just biological, it's also healthcare neglect and lack of government support and social invisibilization. Caregiving is about 24/7 job. It's a chronic disruption in daily rhythms of life of a caregiver without any respite. And caregivers face social misunderstandings, skepticism, and often leading to trauma, which compounds the ongoing grief and suffering of having to bear witness to a profound debility without any formal structures in place. So caregivers have heightened level of anxiety, heightened state of vigilance, because severe ME is extremely unpredictable. And physical labor in this is profound. It's many, many hours. So mothers in this case especially experience marginalization, because they are often, when they are continuously wanting to advocate for their children, they're often positioned as being difficult or angry or hysterical, often leading to a deep emotional distress. While we reinforce the idea of self-sacrificing motherhood, but then it creates a structural power imbalance, which leads to a profound emotional trauma, because it actually directly influences their identities, because their lived experiences are then subject to suspicion, creating profound cognitive dissonance. So 4 foundations, principles of biomedical ethics, which is autonomy, beneficence, which is benefit, non-maleficence, and justice are all compromised and violated when it comes to very severe ME. And so therefore, I wanted to introduce the ethics of care framework, which really provides a powerful support for care and treatment of people, because it's through the lens of compassion, it's relational, it's morally attentive, and it addresses practical needs and moral dignity. Because when I was looking at in terms of care, like what is the ethics of care in severe ME, and then current biomedical ethics don't work. So because the care ethics is actually acknowledges that decisions are not made in vacuum, and caregiver is not just doing things to the patient. So it encourages supportive collaboration between formal and informal caregivers. It advocates for integral social, emotional, and financial support, because the caregivers at this point are providing care that's 24/7, and there's a lack of jobs, and they have immense financial stress. So given my reality is that I'm spending about 16 hours a day, 7 days a week, and caregiving is around 8 to 10 hours. And then spending about 15 to 20 hours a day on actions related to research and connecting and meeting with my fellow researchers and my patient and caregiver partners. So I just want to spend 3 minutes. Sabrina, just give me 3 minutes. So using the ethics of care framework and in collaboration with my close friends and family.
Ruhi, you can have a few extra minutes if you need, no problem.
Oh, thank you. Okay, because I
Yeah,
really want to spend some time here.
Okay.
Okay. So I wanted to use this ethics of care framework because this was very critical in terms of establishing the needs of severe ME, because it's not just, you can't just look at an individual and have standardized protocols. That doesn't work, because each individual's needs are different. Each lived reality is different, and they're not just in isolation. They are dependent on others. They're dependent on their parents or their caregivers or their spouses to be able to help them. So that entirety needs to be taken into consideration. So we took the ethics of care framework, and I took that and I used it in collaboration with my close family friends, and we created an integrated response care plan that respects the needs of very severe ME. And this was in case of a medical emergency, because we were really, really concerned at this point, because with very severe ME, there is no room for error at all. You have to be very careful with their needs. And so in case of a medical emergency, we were very concerned how that would go. And that something happened, how would we transport them to hospital, and what would happen at the hospital, because it's an emergency and you don't have time to go, oh my gosh, these are the things, this is what's happening with this person. So we wanted to establish a plan. And so what we did was we created this integrated response care plan in case of a medical emergency for very severe ME, with my family and friends, in collaboration with our family physician, a neurologist, and we involved the program medical director for emergency department was involved, social worker, and director of emergency services. What it does is, I have put a copy of this for everyone. I've redacted information, ID information, is that it tells you exactly what the presenting issues are, and it gives you the medical diagnosis. It's right there, and it tells you exactly what you need to do in terms of medical emergency, and it's now placed in the medical record. So if we don't want to, if it ever happens that we have to go into emergency, this plan is already in place. And so it also tells you what needs to be done and how they need to be accommodated within the emergency department. And because of the previous experiences we've had within the hospital, it was really important and critical for us to be present in terms of, as a caregiver, needed to be present at all times to be able to advocate for our child. And so all of this stuff is actually included in this integrated response care plan. And so this way, we don't have to be talking about like what needs to be done or advocating or panicking. It's in place. And if there's something happens, it's already stated, this is what we need to do. So in summary, I have juxtaposed 2 field studies on skewed sleep and circadian rhythms with my own experience of complexity of caregiving in very severe ME. And this led us to adopt the ethics of care framework, which was to create an integrated response care plan for very severe ME in case of a medical emergency. The plan also acknowledges the profound debility associated with very severe ME and was put in place to ensure appropriate care is provided in case of a medical emergency. Though this was a milestone, working with medical leaders within the siloed medical system, it continues to be challenging because of lack of government support for the medical system or to accommodate current practices for very severe ME. There is nothing in place for very severe ME and how we are supposed to provide appropriate and formal care for them. And this places an incredible strain and burden of responsibility on caregivers. So I'm very grateful to my family and friends who continue to provide me with support. And I'm especially grateful to ICANN-CME for providing me with a space to explore this very complex and very difficult subject of caregiving for very severe ME visible. And I think that I'm going to end it here. Sabrina?
Perfect. That was a great presentation, Ruhi, and you have lots of emojis flowing, lots of nice comments in the Q&A. So if you want to take a look at that, that would be great. And we are running a little behind today, guys. It's the passion and the interest in so many great topics, and that's a good problem to have. So what we're going to do is, because rest is important, we are going to take our break. It is 4:10. We are going to take a 15-minute break and come back at 4:25. Well, 4:25, sorry, for me, it'll be 3:25 Eastern. So at 3:25 Eastern, we will be back and we will have Dr. Maitland doing her presentation at that point. So we will see you shortly.
Okay.
Welcome.
Greetings.
So we are encouraging everybody to go to their conference program, but we're also posting bios in the chat. Just to give you guys as much time as possible. And you have a lot of fans in the audience. Your presentation, people were very excited about, because I think a lot of us have MCAS and we don't always know quite where to start with it. So your presentation is going to be very exciting.
Okay.
If you want to bring up your slides whenever you're ready.
Yes, ma'am. Mute.
And you'll
Let
be
me
with us
share.
for the panel as well, right?
Yeah, I'll be able to. Unfortunately, my clinic schedule, we're about 1,000 patients in a wait list for our center now. So it's a little bananas.
I'm sure. There's not a lot of knowledgeable people when it comes to MCAS. So you're incredibly valuable to our community, and I'm sure to others.
Okay, is this visible?
Yep, that's perfect.
Okay, let me see if I can. There we go. Perfect. All righty.
So you can start whenever you're ready.
All right, perfect. All right, well, good afternoon, and I want to thank everyone for inviting me. Greetings from Charleston, South Carolina. We're going to have a little chat about a cell that is moving out of the dark ages and trying to understand that this is a cell, for the most part, is trying to help out, but is just terribly confused by an environment that's been completely changed within 30 years, and that's the mast cells. This is the outline of the talk with the dramatic rise of hypersensitivity. And then we're going to be talking about the role of mast cells in homeostasis. And then why we're seeing such a rise in mast cell diseases is basically a maladaptation of this immune cell that's like a sentinel in the tissue, contributing to, instead of tissue defense, it's actually causing tissue damage.
Excuse me,
And
Anne.
then, yes.
There's a little bit of an echo. Is it your microphone or your headset? Maybe there's a little bit of an echo for us.
Okay, let me see if I can move. Let me see if I can move elsewhere where it's quiet. Hold on.
I think it's your voice that we're hearing echoing.
Is this any better?
Can you say a little bit more?
Is this any better?
I think so. Yep.
Yeah.
Let's
Okay.
try. Yep. Let's try that.
Okay, perfect. And then we're just talking about mast cell activation diseases. I prefer that term because mast cells release lots of chemicals besides tryptase, so we don't want to rely on a single biomarker to figure out whether or not someone's having a confused mast cell compartment. So unfortunately, the first impression of mast cells for most healthcare professionals and then patients is in the context of disease. Mast cells were originally identified in the mid-1800s, found in every single human being in every part of their organ systems in 1880s. And then basically they didn't have a job until the epidemic of allergies that started like in the late 1980s in industrialized countries. We're now at a point now where 1 out of 2 Americans has either a delayed or hypersensitivity disorder. Delayed hypersensitivity disorders include the Hashimoto's, multiple sclerosis, rheumatoid arthritis, and you can see from this graph from the New England Journal from 2002, not only were we seeing delayed hypersensitivity disorders, we're also seeing the rise of immediate hypersensitivity disorders, including ones that don't normally thought of as mast cell diseases, including pain syndromes, interstitial cystitis, as well as some neuropsychiatric disorders. And the reason why mast cells got pegged as a criminal in our care is that in 1989, a group of scientists linked the rise of anaphylaxis and allergies to mast cells, and this was the first job that it was assigned. But I wanted to say that mast cells, again, are ubiquitous. They're in lots of different types of organisms. They're in every part of the human body, and nobody really gave a heck about mast cells until in the 1990s. This is a report from the National Institutes of Health that shows that from 1954 to 2010, NIH only funded 1,000 grants for mast cells, and 90% of them focused on the rise of allergen-driven mast cell activation events. So let's go back and try a really quick course on mast cell 101. Again, this is a tissue-based immune cell, so it's not going to be readily seen in the circulating blood counts. It is located in every part of the human body, but especially at any borders that are dealing with the environment. So you're talking about the 20 plus square feet of skin, the linings of the intestinal tract, the respiratory tract, the urogenital tract, and it crosstalks with the central nervous system as well as the cardiovascular system as well. They are uniquely positioned right below the surface area so they can act as a first responder. But interestingly enough, they're right below the somatosensory nerves, which have been recently identified as having receptors that can recognize dust mites, as well as certain bacteria such as strep and staph. So what's really interesting, you can actually see individuals that are having like allergic-like reactions to infectious agents and dust mites without IgE, because it's actually the somatosensory nerves that are telling the mast cells, this is a dangerous situation and we're going to cause chemical mediator release. And the mast cells are also strategically located near the blood vessels, which will allow for inflammatory markers to come into a site that's dealing with a perceived danger. And depending on what the perceived danger is, if it's a bacteria detected through an array of receptors on the mast cells, you'll call in neutrophils. If it's a parasite, eosinophils will be called in. And if it's a virus, it'll be T cells. And this is just to give you an idea of the array of chemicals that mast cells release. Again, excuse me, it's not just tryptase, it's not just histamine. You have chymase, which is primarily available in the respiratory tract, urogenital tract. You have serotonin and dopamine that have the ability to work on blood vessels. You have enzymes that can actually cause gross tissue remodeling. And you have the ability to release chemical mediators to call in other immune cells, as well as complement and immunoglobulin production to help with what's thought to be a danger in causing tissue injury. This is just to kind of highlight the different receptors. And the one receptor I really want to point out is that MRGPX-B2 or D. This is the receptors that are found on both somatosensory nerves as well as mast cells that recognize fluoroquinolones, that recognize certain anesthetic agents, that recognize bacteria that then can cause mast cell degranulation. And so it's important that some of the medications I'm going to tell you to avoid down the road are actually going through this receptor that's causing hypersensitivity reactions. And it's important to understand if your mast cells are misbehaving, why they're misbehaving. You just don't want to control them. You want to identify the fact that the mast cells are warning you something is wrong, either internally or something's coming in that shouldn't, and you need to identify it and try to address it the best you can. And this is just within the past 2 or 3 years, we're starting to understand, and this is mostly focusing on itch, but mast cells and the somatosensory nerves crosstalk all the time. And why this has become such a disarray in inappropriate release of these chemical mediators is because our borders, our skin and the linings of our gut, our respiratory tract, urogenital tract are being hit with microplastics, elements from mold, emulsifiers that are in processed foods that are damaging the lining. And because the lining is being damaged, the nerves and the mast cells will raise to a higher level of alert, potentially maintaining a higher level of danger simply because someone is being inundated with toxins that are irritating the lining. And then that's calling in the first responders, including the somatosensory network, as well as the mast cells. Just to give you an idea of all the different things that these chemical mediators from the mast cells can do, they have proteases, including tryptase and chymase. And again, tryptase and chymase have actually been implicated in the ability of detoxifying venom from anything from stinging insects. Like this might explain why individuals are having large local reactions to mosquito bites, to flushing episodes because histamine and serotonin is being released. You also have the ability to release growth factors, which can modify the connective tissue. And what's really interesting in Ehlers-Danlos patients, either hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome, as well as periodontal Ehlers-Danlos syndrome, of these variants are not due to mutations in the extracellular matrix or the collagen. It's actually due to variants within the innate immune system, which have the ability to impact the function of the mast cell compartment. And this is just to emphasize the fact that why women might be more problematic going in or out of their menstrual cycle, or with the onset of puberty or the onset of perimenopause. Mast cells are also armed with estrogen and androgen receptors, which can then modify the action of the mast cells as well. So it's not unusual to hear the story of women who become pregnant, a third get infinitely worse with their hypersensitivity disorders, simply because the estrogen is manipulating the mast cell compartments. And so what we've seen in the past, I would say 30 years, is a dramatic change in the environment for individuals, and those that are showing signs and symptoms of mast cell disease or autonomic dysregulation or downstream remodeling, such as acquired connective tissue issues, is that those borders are dealing with a completely different array of insults compared to what has been going on for millennia upon millennia for these first responders for surveillance and tissue response. This is a paper that came out of University of Virginia. Dr. Platts-Mills has identified that one of the reasons we think we're seeing such a huge rise in mast cell diseases and also autonomic dysregulation. And when you have chronic neuroimmune dysregulation, you're going to end up with impaired remodeling in tissue that's being injured. We have dramatically changed our environment, what we ingest, what we wear, how we even spend our time. We've gone from a population that spends maybe 60% of indoors in the 60s and 70s to now 90%, where now you're subjected to the building materials, the clothing materials, the ventilation system, which may be hitting your borders with chemicals that are stripping the border, injuring the border, and improperly calling in the nerve mast cell first responder. And so some of the barrier damaging agents that were identified in this article by Professor Adkis out of Europe is dust mites actually have enzymes that can directly activate the somatosensory network. There's certain bacteria, when it comes to viruses, SARS-CoV-2, toxins from laundry or dishwashing agents. I actually had a child that developed a contact dermatitis who was 2 years old because the bottle was being soaked in heavy detergent that was actually stripping the skin and then activating that nerve mast cell component. Environmental tobacco smoke. If you live within 500 yards of a major road where you're exposed to diesel exhaust and ozone, and then you have nanoparticles and microplastics. All these are insults to the barriers that's going to activate that somatosensory mast cell response. So we're really living in a toxic environment in places that have been overly industrialized and quote unquote modernized. So when we want to talk about mast cell activation syndrome, there's an issue that we don't have enough research to identify whether or not mast cells are misbehaving or not. If we just rely on a tryptase, I can tell you if a child has anaphylaxis to peanuts, tryptase is not going to be elevated. So we have to develop other techniques to understand if this person is showing signs that mast cells are misbehaving, then what kind of testing can we verify? It's kind of like looking for somebody who's having a heart attack. We just don't rely on the troponins. We just don't rely on the EKG. We have to look at different avenues before we tell somebody we don't think the mast cells are misbehaving in the situation. So mast cell activation syndrome was actually coined back in 2011 when there was a large rise in individuals that are having hypersensitivity disorders, and it wasn't due to systemic mastocytosis, and it was negative, and allergy panel tests were negative repeatedly. So mast cell activation syndrome is simply defined as, do you have signs or symptoms affecting at least 2 organ systems as displayed in the first panel? Do you get better with medications that target chemical mediators that cause hypersensitivity reactions? Heparin is released, but it doesn't cause a hypersensitivity reaction. Serotonin is released, but it doesn't cause a hypersensitivity reaction. So it's really important to kind of focus on medications that interfere with the major players in this space: histamine, leukotriene metabolites, the actual prevention of degranulation. And I'd like to emphasize here, mast cells release chemicals in more than degranulation pathways. There's also de novo secretion of new mediators that can also cause a hypersensitivity event. So omalizumab, chromones, and cotofin may not be helpful. And lastly, after you get a good story, are you able to identify mast cells misbehaving? Remembering that this is a tissue-based cell, you really want to look in the tissue. For instance, all these individuals that have irritable bowel syndrome, why not look to see whether or not the mast cells are misbehaving? Because the matter of fact, the first case study that was described here in this paper was a joint effort between allergy, immunology, and the gastroenterology division. They went into an IBS clinic and simply asked them, outside of your alternating diarrhea and constipation and bloating, do you have rhinitis? Do you have asthma? Do you have neuropsychiatric issues? And by asking a different set of questions and then doing a different set of testing, all 20 patients that were identified in this study were found to have a mast cell disease. And they were put on initially mast cell challenging agents or suppressing agents, but eventually it's really important to figure out why the mast cells are misbehaving. And this is what we're doing in this slide, breaking out the fact that you have individuals that have broken mast cells. You have an evidence of systemic mastocytosis, which can be a mutation in the c-KIT product or any of the downstream signaling events to that receptor. We have one that's a little bit more prevalent, and those are individuals that have an extra copy of the gene that encodes tryptase. The alpha tryptase gene is called hyperalpha-tryptasemia. 7% of the Caucasian population have it, but what's really interesting is tryptase gets released. Not all individuals that have this autosomal dominant inherited genetic phenotype actually are symptomatic. So again, we're talking about the fact that mast cells are under the control of the local microenvironment. And what in the microenvironment is keeping the mast cells under control? Is it the somatosensory network? Are there elements of the connective tissue that's trying to keep the mast cells in check? So these very potent chemicals are not inappropriately released and then contributing to these hypersensitivity disorders. I would have to tell you, and I'm going to show you in the next slide, the overwhelming individuals that come through my practice, it is the mast cells being good soldiers, but following bad orders. This is a study that we had done. It was a retrospective analysis of over 900 patients that came through my private practice when I was in New York. And then we had basically went, and they all got full immunological testing. They got evaluated for immunodeficiency syndromes, and they were also evaluated for evidence of musculoskeletal hypermobility. And what I found to be fascinating is that 1 out of 5 individuals were found to have musculoskeletal hypermobility, hypogammaglobulinemia, everything from common variable immunodeficiency to selective IgA deficiency, and they had evidence of immediate hypersensitivity disorders, such as the symptoms that are portrayed in the left-hand panel. So when it comes to patients that come through saying, I have mast cell disease, I try to verify whether or not mast cells are driving the issue or are they responding to another insult? It's kind of like that red light that comes on your car saying something's wrong with the engine. Look under the hood and see what's going on. And because of that study that I just showed you, we routinely screen for hypermobile Ehlers-Danlos syndrome and hypermobile spectrum disorder using this criteria from the French EDS groups. If you answer 5 positive to these 9 questions, you have over a 98% specificity and sensitivity for an EDS variant. And it's really important that you undergo formal testing to kind of confirm, is this a defect in the connective tissue itself, or is it a defect in the innate immune system that's contributing to this musculoskeletal hypermobility phenotype? We also know, and this is what we found very interesting, this is a review article that came from the American Academy of Asthma Allergy Immunology, where we finally admitted the fact that dysautonomia travels with mast cell disease. So not only do the patients get screened for hypermobility issues, they also get screened for postural orthostatic tachycardia syndrome, simply by doing orthostatic measurements. I have a tendency to keep away from tilt tables because we just don't know what's going on in the neck, and we don't want to cause another problem while we're trying to figure out what was the reason the individuals are being evaluated. Lastly, once you determine that the mast cells are misbehaving and you've been able to assess all the different things or all the different comorbidities that may be driving the mast cells to inappropriately release these chemicals, you now will tailor the therapies based on what the triggers of the mast cell activation events are. So if you're able to identify allergen-specific IgE, you have these therapies available. If you're able to identify that they have evidence of a Borrelia infection, which I believe was talked about earlier today, or had mono and had persistent Epstein-Barr virus, you need to go after identifying whether or not there's a pathogen, and then going after therapies that might either reduce the burden of the pathogen, or, which is not the case in some of these individuals, they don't have an immune system that is able to clear this pathogen. Then we're also, again, we've identified a lot of individuals that have deficiencies in other components of the immune system that the mast cells are trying to make up for until appropriate help arrives. And then if you have enough tissue damage happen, eventually you may develop an autoimmune phenomena. So it's important to identify whether there's evidence of autoimmune disease as well. Lastly, we're using a lot of non-medicinal approaches using physical therapies such as acupuncture, acupressure, vagal stimulators to help restore that balance between the vagus and the adrenergic system. We know that if somebody has cervical spine instability, you can have the ability to compromise the vagus. By compromising the vagus, you're going to be able to cause more inflammation. So by restoring that balance between the adrenergic system and the vagus system, you might be able to restore more tolerance in the immune compartment as well. And lastly, interestingly enough, and we need more data to support the use of oxygen therapy, but reducing the tissue stress, allowing more resources for the muscles to help out maintaining that stability of the autonomic nervous system is going to be really important as well. And lastly, an ounce of prevention for anyone undergoing procedures, whether you're talking about a radiology exam, a vaccination, or a surgical procedure. It's really important to understand there's certain medications that you should avoid. There's certain medications that you should utilize. This is one of the forms that is readily available from the Mast Cell Disease Society that can be downloaded. And again, a lot of these medications are not going through the immunoglobulin receptor. It's going through that MRG receptor that's identified on the right-hand side of the figure on the right. So, summary and challenges of mast cell activation disease, including mast cell activation syndrome. Any organ system can be involved with mast cell dysregulation. You can have, interestingly enough, the 3 most common manifestations and some of the limited studies that have been done with cohorts, typically it's skin, gastrointestinal tract, as well as neuropsychiatric issues. So these are the symptoms of mast cell activation disease. You can have upper or lower respiratory involvement in the form of shortness of breath. You can have cardiovascular manifestations in the form of dysrhythmias or postural orthostatic tachycardia syndrome. You can have actual inflammation involving any one of the epithelial borders, including the skin or the linings of the internal organs. I think it's really important to understand that mast cells are going to be involved because that's their job. The question is, should they be involved or not? And if they're not supposed to be involved, why is that the case? Does this person have an undiagnosed connective tissue issue? Does this person have an undiagnosed immune deficiency or overreactivity in the form of an autoinflammatory syndrome? I think it's really important to understand that in the majority of patients, again, the mast cells are acting as a red flag saying, I'm trying to help, I need help. You need to identify why that's happening. So this is the finishing slide on emphasizing diagnosing mast cell activation syndrome just tells me your mast cells are twitchy. It doesn't tell me why. It's really important to figure out why that's happening, but you start off with doing a comprehensive organ system analysis of impacted symptoms, impacted tissue symptoms. Then you see whether or not you can identify the classic mediators that are associated with hypersensitivity events, understanding that mast cells are involved in lots of different homeostatic mechanisms besides, releasing histamine. And lastly, why this is happening is we're having a lot of damage to the tissue itself by environmental changes, climate change, use of processed foods, overly processed foods, microplastics. So I encourage a lot of patients to be careful about their clothing, to stick with cotton, try to avoid nonstick pans, use glass as a vessel for your beverages and food. And it's really important to understand mast cells are not doing this by themselves. Please understand that they have a job to do in frogs and in humans, all about tissue defense and tissue repair. And if they're not doing that, they're doing it because they're trying to identify another situation as well. So this is just to say that we're trying to get away from this siloed care when there's mast cell disease, autonomic neuropathy, or connective tissue issues. This is the model that we have at MUSC. We're threefold on the clinical side, research side, and I've had the pleasure of lecturing to at least half the departments here at the Medical University of South Carolina. And I appreciate the opportunity to take my partial Charleston, New Yorker attitude and present, and really want to emphasize that you really shouldn't put test results ahead of a patient's story. It's not wrong to suppose that if you can't measure it, you can't manage it. It's a costly myth, and we can spare people this burden of a chaotic medical process by just allowing them to tell their story and giving and validating the fact that this is going on.
Awesome. Thank you so much. What a fantastic presentation. I mean, wow, so much covered. So thank you for that. And we will see you again in the panel.
Yes, ma'am.
Perfect. And if you want to see the Q&A and see if there's any questions there, I think there's some questions there for you. Feel free to take a stab at answering them because we have some other questions for the panel.
Okay, perfect. Thank you.
Perfect. And Sammy and Carrie, are you able to bring up Sammy's slides?
Yep, I'll do that right now.
Perfect. Hi, Sammy. Welcome. Thanks for
Hi.
being patient with us. We're running a little bit behind today. Sorry about that.
No
So much
worries.
great information. So we are going to bring up your slides and then you can get started.
Thank you so much. Just go to the first one if that's brilliant. Thank you. So thanks so much for inviting me today. Hello, everybody. I'm here on behalf of the paediatric patient community. I'm here as a mother of a young person with long COVID and POTS, a patient with long COVID and POTS myself, and the founder of Long COVID Kids and Friends. Next slide, please. Our personal experience led to the creation of Long COVID Kids, which began as a grassroots organisation to support families, children and young people feeling isolated, overlooked by healthcare and lacking guidance. LCK provides direct support for over 11,000 members, including families in the UK and worldwide, USA, Canada and across Europe. So many of our young members have overlapping illnesses, including ME. Our mission extends beyond direct support. We work closely with both national and international partners to advocate and advance understanding and care for long COVID and overlapping conditions. Back in 2020, we didn't have the understanding that we have now about how many of these conditions intersect. We collaborate with organisations including the WHO, the NHS, the National Health Service, research teams from various academic and medical institutions, charities focused on health, education and advocacy, as well as prevention. And unlike many organisations, we have not yet received government funding. Our support and advocacy work relies entirely on the dedication of generosity of volunteers, benefactors and fundraisers. Our grassroots spirit allows us to remain directly connected to the needs of families and drive meaningful change from the ground up as well as from the top down. Next slide, please. Are you listening to their language? When we listen to the voices, to the young voices, we can learn what it feels like to have long COVID or an overlapping condition from their perspective. We can give young people a greater sense of control, autonomy, confidence, and empowerment, and they can help shape any plans to support their daily living. When we asked children to describe their experiences in their own words, it was striking and heartbreaking. They told us it feels draining, depressing, exhausting, scary, horrible, intense, and never ending. Many said it makes them feel sad, angry, anxious, helpless, broken, lonely, and in pain. When they spoke about fatigue, one young person said, "It's like my energy is leaking out, like air from a balloon." Another said, "It's like someone is pushing me down all the time, and I wake up feeling just like I haven't slept at all." For some, brain fog is one of the hardest symptoms. My mind is just blank, like white walls. I can hear the question and the answer, but they won't join up. My brain feels like treacle. And beyond the physical symptoms, children spoke about isolation and loss of identity, missing friends, feeling left behind, and being cut off from school life and activities that once defined them. These voices remind us that these conditions aren't just about a body. It affects a child's whole world, their confidence, belonging, friendships, and sense of self. It's vital that we keep listening to them and amplifying their voices, collaborating across health and education, community settings, raising awareness and reducing stigma. You can read more about the language children used in our blog, Exhausting and Painful. It's linked on the slide and easily found on our website. In a recent research project, one young person said, "I remember being sat in the doctor's office and honestly being near tears because I was like, I'm not believed. She's not trying to help. You can see she's not even believing me. I still remember that day and being so distraught when I came out because I thought no one was ever going to believe me and maybe this was my fault." That young person was 17. Children living with complex and often poorly understood conditions, including long COVID and ME, may not have a point of reference for what's normal. After all, their experience of health isn't normal. And therefore, it's our job as caregivers to listen to the language they use when describing their health, thoughts, and feelings. We need to try to work out where they may need extra support, accommodations, and interventions to help them live the best possible life they can with the complex condition they're dealing with. They may not have the language they need. Next slide, please. Although it hasn't always felt like it, over the last 5 years, it's become increasingly clear how fortunate my family's been. We had the skills and technology to advocate for ourselves, and when we ran out of options, we could sell our home to pay for private healthcare. Even with those advantages, caring for a child requiring additional care while constantly fighting to be believed has been emotionally exhausting. The broader impacts continue to touch every part of our life. In 2023, Long COVID Kids collaborated with the University of Derby on a survey to try and find out a little bit more about the care needs of children with long COVID. One of the findings showed that before COVID, 92% of families in the survey reported they had no care needs. After their children developed long COVID, 40% of children required a lot of care and 33% needed some level of ongoing support. That's a seismic shift. And it isn't just about medical care. Being a caregiver means constantly searching for information, trying to interpret it, and then advocating in every direction, negotiating with schools, employers, family, friends. The list honestly just never ends. Days previously filled with family activities are filled with booking appointments, filling out endless forms, taking part in research surveys out of utter desperation, and all the while managing stigma, guilt, and sheer exhaustion. Families tell us they want nothing more than to do what's best for their child, but medical professionals often call them anxious parents. The anxiety, burnout, and isolation can become overwhelming, but it's not because the parents are anxious, it's because they care. And this is where we have to recognize these families are doing everything they can. When systems don't work, these families are the safety net for these children. And this is not sustainable, not for the families and not for the children. Broken systems impact childhood, and overwhelmed families need additional support. And the children feel the weight of this burden, even when the parents do the best to hide it from them. Next slide, please. I wanted to touch on some of the systems creating barriers, which you can see on this slide. I'm just going to focus on education today. Young people need assessment for individualised support, including consideration for educational and healthcare plans, or the equivalent in Canada. They need accessible, flexible learning options, including remote and hybrid pathways to support their education in ways that meet their health needs in school or at home, however their education looks for them. Education policies need to ensure pupils are not excluded from school activities for events such as trips or prom due to health condition-related attendance absences. It's really important that young people with complex health conditions get to enjoy the fun stuff too. School staff, including teachers and pastoral leads, should receive training and know how to respond appropriately and supportively to pupils who report symptoms or concerns. And schools need to make reasonable adjustments to ensure children with complex health conditions are not disadvantaged. They are entitled to their education too, even if it doesn't look the same as everyone else's. Next slide, please. Supporting families is not just a parental duty. Supporting children is not just a parental duty. It's a collective societal and healthcare responsibility. As they say in Nigeria, it takes a village to raise a child. This is especially true when a child is, or in some cases both the parent and the child, chronically ill. Families affected by ME, long COVID, or any overlapping illness face constant strain, and they need help to carry the weight of caregiving, advocating, and managing daily life. I'm going to share two examples with you. In Colin's story, when Colin's daughter was still trying to attend school, he would drive her to class and then wait nearby in a cafe, working offline until he got the call about 30 to 60 minutes later to pick her up again. Without Colin's flexibility, his wife, a teacher, may have had to quit her job, which would not have only increased the financial burden, but also meant the loss of an experienced teacher to the workforce. In Helen's story, Helen is a single mother with long COVID. Her sole caregiver for her 11-year-old daughter, Anna, who's been mostly bedbound since 2020. Anna's symptoms are so consuming that leaving the house is nearly impossible, and the invitations for playdates and birthday parties have long since dried up. Helen's network of friends and family have largely fallen away, and some choose to believe that her condition cannot be that bad and that the situation isn't their responsibility. On top of managing Anna's health needs, Helen struggles to manage her health, and the constant need to advocate for them both is relentless. Her situation makes it impossible to take on paid work from home. She can't commit to set hours, and Anna's care needs vary from day to day, even hour to hour. These two examples only scratch the surface of the burden families and caregivers face. There are thousands more stories like those we hear every day in our support service and on social media. This overwhelming burden leaves children and young people vulnerable and families burnt out. Children and young people themselves tell us that they feel guilty for making things difficult for their families. They feel they are the burden and they are the problem. And they worry about how they will become independent in the future and take the pressure off their family. We must acknowledge these worries and these challenges as collective responsibility, advocating for more support and understanding at every level. Young people need hope that we are considering their future needs and not just setting them aside. Next slide, please. Long COVID Kids has been trying to plug gaps since 2020. I know that we're relatively new to this, but it feels like a long time already. Our mission has always been to ensure that no family will be alone. We have a website, a comprehensive support guide, peer support services offering sessions for parents, caregivers and children themselves for validation, signposting and connection. Our online choir welcomes children with the condition and their siblings or their friends to come and join an online, fun, inclusive occupational activity. It's free and for anyone who would like to join. We have downloadable resources, which we hope to expand to help families advocate for themselves. And we have an educational toolkit, which is a video series, handbook, downloadables, packed with information and solutions for teachers and schools, even if it's not condition specific or specific to another country, the information, the content still applies. It's still really, really educational. So I would urge you to have a look at it. Next slide, please. I just want to take a moment before I finish to recognise the additional challenges young people with these conditions face while navigating their childhood, their one childhood. Rosie Pigeon, an artist and advocate, has long COVID. She's captured the dismissive comments children and young people heard in the earlier part of the pandemic. Her work highlights the gaslighting that many experience and sadly continue to experience when seeking understanding and care. I want to finish with a poem by 16-year-old Abby, who was infected with COVID in September 2021 and now lives with long COVID. Abby's words speak powerfully to the struggles of navigating healthcare as a young person with this condition, and I will try to do her poem justice. It's just a small section of it. Abby's poem is called Believe Us. Medical care should be a team effort between the patient and the doctors. That's how it should work. It shouldn't be a battle to get what we need or a constant argument, a fight to be believed. Medical gaslighting isn't just annoying, it's traumatic, humiliating, physically and mentally destroying. So listen to us, all of us who are unwell. Fight for us, not against us. Believe us and help us heal. Addressing the burden of long COVID on children and their families and ME requires empathy, understanding, and a collective effort. These are kids who, like any other, should be enjoying school, friendships, and growth. Their lives have been altered not by choice, but by circumstance. Before they are patients and statistics in research studies, they are children. Children who crave joy, connection, support, and yet they face daily reality marked by chronic symptoms, isolation, and systems that fail them. It's our responsibility as professionals, as communities, as society, to listen, to believe, and to act. Thank you for listening.
Thank you so much. That's such a fantastic presentation, and you have me all choked up. I'm sure I'm not the only one. We don't hear from young people enough on this topic, and I commend you for all the work that you've done and that you're doing. And you may not have been in the space for very long, but you've had a massive impact. So thank you for everything you're doing, and we need to do a lot more.
Thank you.
Yeah, so thank you for being with us today, and stick around for the panel. We have Dr. Rebecca Ryan, who's going to come on now and give us a presentation, because we have been for quite some time now needing some support in the area that she's going to talk about. And we have a very hard time getting knowledge and support in this area, Dr. Ryan. So thank you so much for joining us despite the time that it is in your area and the the preparation that this all required. We really appreciate you doing this for us.
Thank you very much for Sabrina for inviting me to talk. I'm very pleased to be here. It's not too early now, and I hopefully you've all got your attention span still going because this is the last session of the day. So I'm talking today about the gastrointestinal manifestations that we see in ME, and what most people need to understand with ME is that whilst I don't specialise in ME, most patients with ME will have underlying autonomic dysfunction. It may or may not meet the criteria for POTS. They have aberrant mast cell activation and degranulation. The MCAS criteria are difficult to meet, but the diagnosis or the label is not really important. It's understanding how these abnormalities in both the autonomic nervous system functioning and the mast cell functioning are affecting the gut. And the way I view irritable bowel, or what we now call functional gut disorders or disorders of the gut-brain interaction, is that they are the gut manifestations of POTS and MCAS. The trouble I have, though, is convincing my colleagues that POTS and MCAS are true disorders, because the traditional teaching is that DGBIs, which is now what we call them, are all psychologically stress-induced. So so irritable bowel got renamed as functional gut disorders because we realised that it wasn't just the bowel that could be involved, it could be the entire gut. Functional has obviously, particularly for this community, negative connotations, implying that it's psychosomatic or all psychologically driven. I understand and appreciate that, but I quite like the word functional gut disorders because it's the functioning of the gut that's abnormal. So what is the function of the gut? It's to move things, secrete hormones and water and liquid, digest food and absorb food. And so it's those functions that are abnormal. So when I talk about functional gut disorders, I'm talking about those symptoms. We now call them DGBIs, which doesn't really roll off the tongue. For the purpose of this talk, this is the most common type of symptom or GI manifestation that patients with ME will experience, and it will assume that you've had basic bloods, scopes, and nothing else has been found. The way I approach my patients when they come in with functional gut symptoms, most of my patients have already had scopes and have come to see me for a consultation, is the current symptoms that they're complaining of, is it being driven by the abnormal mast cells or the underlying MCAS, or is it being driven by the hyperadrenergic state or the autonomic dysfunction, or a combination of both? And then when I look at the symptom, I also look where in the gut is the symptom arising from. Is it an outlet or a rectal or an evacuation issue? Is it a colonic problem, so the storage and movement of feces, or a primarily upper gut, stomach, esophagus symptom? Or is it any combination of these three? And I find this approach allows me to manage most of my patients' symptoms. So this is a little diagram that I've sort of drawn up to show the gut-brain axis, where the gut and the brain are linked by the three different arms, or what I call them. So there's the HPA axis, there's the autonomic nervous system with both the sympathetic and the parasympathetic, which is predominantly for the gut, the vagus. And as you all know, that they're always, both the parasympathetic and the sympathetic are always on. It's just which one's doing more at any one point in time, and the immune system. And on the healthy side, where we have an intact gut barrier, We have happy, healthy bacterial population, or what we call eubiosis, whereas in the disease state, or when the gut-brain axis becomes constantly activated, we have leaky gut or increased intestinal permeability, and dysbiosis develops. Now, the gut-brain axis, what it's its role, the way I view it is it links not just the gut and the brain, it links all the different bodies, systems and organs together to allow for coordinated control and to maintain you in a state of health. Where it comes into, a lot of patients, again, don't like being told that they're in fight or flight, but the gut-brain axis is essential for protecting us from danger. So you either fight or run away from the danger and survive, or you get eaten by the lion, say, and you die. But when you run away, or when you're in a fight or flight situation, such as running away from a lion, the whole process takes 5 or 10 minutes. If you haven't escaped the lion by that time, they've caught you and eaten you. So it's a completely energy-consuming process. The body gives up everything it's got for a short burst of energy to get away from the danger so it can survive. But when the gut-brain axis becomes constantly activated because we're continually exposed to danger or stresses or threats, it's now constantly activated. You're not supposed to run a marathon at the speed of a 100-meter sprint. So when you're constantly in that state of fight or flight or running away from a lion, it's the actual mechanisms that the gut-brain axis is putting into play to survive that are causing all of your symptoms. But the gut-brain axis doesn't care. It doesn't care how you feel, how miserable you are, because you're alive, and that's its main role. So when I think of mast cells, and we had a brilliant talk earlier, I like to think of the mast cells as our danger cells, and they protect us from danger. And I won't go into all of this. So in the gut, I like to view the role of the mast cells to protecting us from eating things that are going to kill us, so poisons, toxins, or infectious microorganisms. So how will mast cells protect us from these situations? So if we eat something that we're highly allergic to, it'll induce an allergic or an anaphylactic reaction so that the poison doesn't actually get down into the gut, the mouth and the throat close off. If it manages to get into your stomach, it'll induce nausea and vomiting to vomit up the toxin. If it manages to get down to the colon, then it'll cause diarrhea and flush out the danger. However, if you don't know that what you're eating is dangerous, so say in some people it's gluten that's the danger, but they didn't know that gluten was a danger, then they'll keep eating it. So the mast cells will then start to cause pain to discourage you from continually eating something that's dangerous to your body. And if despite this pain you continue to ingest this danger, then the mast cells will induce visceral hypersensitivity, so that if you keep eating the same amount of the food that's causing the problem, you'll get more and more pain, or you will need to eat smaller and smaller amounts in order to get the same symptoms. And in MCAS, I view the mast cells as becoming overly protective. And so in this situation, sometimes just food is sensed as a danger. And so these patients, when they eat normal, healthy food, have reactions that can either be in the gut, or these reactions can also cause extraintestinal manifestations. And sometimes just the passage of the food, and as it's being turned into feces, passes through the gut, it starts to cause disabling symptoms that it shouldn't. So how does the autonomic nervous system or the sympathetic nervous system affect the gut? So most of my patients have a hyperadrenergic subset or form of POTS. And when we look at the sympathetic nervous system, one of its main roles is controlling blood flow. So when you are faced with a danger or a stressor, the sympathetic nervous system will redivert blood flow from the non-essential organs to the essential organs. So picture a lion. You don't need your gut to run away from a lion, so your blood will get rediverted away from the gut to the heart, the lungs, the muscle, and the brain so that you can run away from the lion. And so the gut gets shut down. Your sphincters contract and the gut motility slows down. And then this leads to a significant number of symptoms that we then label irritable bowel. And one of the most important concepts that I want you to take away from the talk today is the concept of fecal loading. So before we go any further, what's fecal loading? Constipation is a symptom that the patient complains of. They say that they're either passing a hard motion, and this is the Bristol stool chart, so one of type 1, 2, or 3, or they're not passing a motion very often. So they might pass a completely normal motion once a week. Defecatory dysfunction, again, is a symptom, and it's a symptom where a patient says, I have difficulty getting my motion out. Now, it's going to be more obvious when the motion is hard. So sometimes if it's normal or loose, the patient's not experiencing those symptoms, even though they're not evacuating properly. And fecal loading is a finding or a clinical sign, and it's the presence of hard feces in the colon. You're supposed to have feces in the colon, but they're not supposed to be hard. And so the most common finding on examination is when you push on there, it's tender because you're pushing on the hard poo. So how does POTS cause fecal loading? So the normal colonic function is that as the feces enter into the colon from the terminal ileum, they're in liquid form. And then the job of the colon is to move the feces whilst reabsorbing the fluid so that by the time the feces reach the rectum, it's that beautiful sausage or the night type 4 motion. But when we have POTS, if you look at the hyperadrenergic component of POTS, the sphincters contract. So your anal sphincter will contract, which will make it difficult to evacuate your motion, and it will further slow down colonic transit. Colonic motility slows because remember, you're running away from the line. And so it allows more time for water to be reabsorbed from the motion and become hard. Then if you look at the hypovolemic component of POTS, so this is going to further dehydrate the feces because the blood, if you're not adequately consuming enough salt and water to control the hypovolemic component, the POTS is going to look for fluid anywhere it can find. And there's this huge amount of fluid in the colon. And so it starts to reabsorb that fluid to try and replace the hypovolemia. And then this is going to be exacerbated by inadequate salt and water intake because no one knows or has been told when they've got POTS exactly how much salt and water they should be drinking. They've got disabling GI symptoms, nausea, severe pain that limits their ability to take in enough salt and water. There's a high prevalence of neurodivergence, and particularly in the autistic population, there is a high prevalence of ARFID, avoidant restrictive food intake disorder, due to the sensory sensitivities related to the taste, texture, smell, look, or consistency of the food. And then in severe MCAS, there are a lot of food allergies and intolerances, which mean that patients can't have a lot of food groups, or there is so much fear that they're going to have an anaphylactic reaction that they self-limit foods that they're concerned about. But the end result is that you end up with hard feces in the colon, which is fecal loading. Now, this is the tricky point because fecal loading can cause no GI symptoms or any GI symptom. It is the great mimicker. And the basic pathophysiology is that the enterochromaffin cells, so these are the hormone-producing cells in the gut. We have lots of different types and they release them. The ones in the colon predominantly release serotonin, and they have mechanical or mechanoreceptors on them, just like the mast cells do. So when the hard feces or trapped wind pushes on these mechanoreceptors, it releases serotonin. And then depending on how many serotonin receptors you have in your gut, or in your colon, it will depend on what symptoms arise. But basically, by acting on the serotonin 3 and 4 receptors, it's going to stimulate peristalsis, pain, water, electrolyte, and mucus secretion. So you can see that not only does fecal loading present classically as constipation, but it can also cause pain, urgency, and diarrhea. And then there's the serotonin will travel via a vagal reflex where it goes up to the brain, back down to the stomach, and it slows gastric emptying. And the purpose of this is, I explain to my patients, the colon is so full of hard poo that it sends a signal to the stomach and it says, there's no more room. So can you please stop sending any more food down? So the colon directly influences gastric emptying. So in constipation predominant IBS, it's easy to see, but in diarrhea predominant IBS, they have more mucosal serotonin receptors. And so when the fecal loading activates these mechanoreceptors on the EC cells, it leads to pain, urgency, and diarrhea driven by the hard feces. But the most misunderstood thing is that the most common cause of diarrhea is actually fecal loading. And I have patients that have been treated with anti-motility or gastrostop for 20 years, and their diarrhea has not gotten any better. And I give them laxatives and their diarrhea resolves. And then the gastric symptoms lead to symptoms that mimic gastroparesis or can cause acid reflux. If the stomach can't empty and the GO junction or this gastroesophageal sphincter is loose, then the high pressure in the stomach, because it's not emptying, is allowing acid to go up. So this is, I won't go into this, but this shows the various actions of serotonin released on the different types of cells and the receptors involved. So indirectly, so that's how fecal loading directly causes symptoms, but it also indirectly causes symptoms through the mast cells. So as we said, the mast cells also have mechanical receptors on them, and they have serotonin receptors. So it's a double whammy. The fecal loading directly activates the mast cells, but the serotonin released from the EC cells also activates mast cells, and then mast cells release serotonin and also have more serotonin. So there's a feedback loop there. So some of the mediators you can see here, and iron deficiency I find is almost universal in my MCAS patients. And it's because various reasons, but mast cells release heparin, which makes micro scratches or cuts or anything that wants to bleed more. And then inflammatory mediators switch off iron absorption from the gut. And the problem is, as the ferritin level gets lower, the mast cells become more sensitive. So again, there's that feedback loop. And the mediators can also cause visceral hypersensitivity, which doesn't have to be limited to the colon. It can occur anywhere in the gut. Diarrhea via increased water and electrolyte secretion, and it can also contribute to upper GI slowing as well. And so again, the symptoms and how many of your symptoms are caused by the mast cells really is dependent on how many mast cells you have. Now, a lot of people are fascinated by, and I get questioned, can I check my mast cells? And I did it in over 200 consecutive patients with functional gut symptoms, and then I stopped doing it. And I found that there was no real correlation between symptoms and mast cells until I realized that, well, if the mast cells cause those particular symptoms, you'd expect them to be up. So constipation, we wouldn't expect to see lots of mast cells, and we don't. But diarrhea predominant irritable bowel, we would. So when you look, you'll see if a patient has a clinical picture of diarrhea predominant IBS or functional dyspepsia, which makes it feel like you've got an ulcer, but you don't have an ulcer, or functional reflux, it feels like you've got acid reflux, but it's not acid reflux and it doesn't respond to acid suppression, then the mast cells are playing a role and they'll be elevated. But I don't actually check mast cell numbers anymore. I just assume all my patients with functional gut symptoms have autonomic dysfunctional POTS or aberrant mast cell activity in the gut or MCAS. And fecal loading begets fecal loading. And I find that in functional gut symptoms, there are just so many feedback loops that you have to break. So the POTS slows down the GI emptying, the colonic emptying, which leads to fecal loading. Serotonin release from the EC cells can cause any number of GI symptoms on its own, or it can activate and drive the underlying mast cells, which can cause the mast cell-driven symptoms. But the bidirectional communication between the autonomic nerves and the mast cells means that they will then drive the POTS. And so in the gut, I don't believe for functional gut symptoms you can have POTS without MCAS or vice versa. So whatever makes the POTS worse is going to make the MCAS worse. Whatever makes the MCAS worse is going to make the POTS worse. But whatever makes one better will make the other better. So how do we treat fecal loading? Well, first of all, you've got to realise that's what the underlying pathophysiology is. So what are the 3 necessary requirements to evacuate motion or feces from the colon? Well, you need a rectum that can adequately sense the feces and coordinate with the pelvic floor to empty the feces. And defecatory dysfunction is very common. And so it's extremely important, particularly because of the comorbidity with connective tissue dysfunction, that all patients with functional gut symptoms see a pelvic floor physiotherapist. We need feces that are soft enough to be moved through the colon. And in some patients that have had long-standing symptoms and severe untreated POTS for a long time, they have had so much water and salt reabsorbed from their feces that their feces are concreted, and a colon cannot move concrete. So you need to be able to adequately replace the salt and water to control the hypovolemic component of the POTS so that that's not continuing to drive water reabsorption from the colon. And then you need an osmotic laxative. And my osmotic laxative of choice is now magnesium citrate, because I'm seeing since COVID a lot of reactions to the PEG-based laxatives, such as what we have, Osmolax or Movicol. But what I say to my patients is you need to have enough salt and water, because the laxatives work by pulling water into the bowel. And if you are still hypovolemic, it's going to pull it back again. So they're not going to work. And consistency is the key. If you can do 2 litres of water and 5 grams of salt every day, then that's much better than trying to get 3 litres and 10 grams one day and not getting any the next day. And sometimes the fluid deficit is so severe that IV fluids are necessary. And I usually give 2 litres weekly for, anywhere sometimes up to a couple of months in order to rehydrate those feces so that they turn from concrete back into feces. And then you need adequate colonic motility. So the POTS is slowing down the colon, so you have to control the POTS. And so this is how I got into managing POTS, because if I don't manage your POTS, I will never get on top of managing your gut. And a pro-motility agent. And this is important because when you have hypermobile EDS or a connective tissue abnormality or dysfunction, the connective tissue provides the tone to the colonic wall. And so these patients have this floppy bowel that just doesn't contract very well. And my agent of choice is prucalopride, which stimulates the serotonin receptors in the whole gut, not just the colon, or if they can't tolerate it, mestinon or pyridostigmine, which can have some benefit for POTS as well. And so my second approach, once I've decided, is this symptom predominantly a POTS or an MCAS? And if you have to hedge your bets, it's usually more POTS than MCAS. Then I ask which area of the gut is driving these symptoms. And so gastro is very simple. It's a tube with 2 openings. You can't keep stuffing food in the top if you're not letting it out the other end. And a lot of people don't realize this. And so the symptom that the patient complains of may be related to the organ that we all blame for that symptom, but it may be a manifestation of of a downstream blockage. And so symptoms can arise because the rectum is not allowing feces out of the body, the colon can't move the feces, or the upper gut's not working itself, or any combination of these 3. So regardless of the symptom that the patient comes in with, you start at the bottom and work your way up. So you address the adequacy of defecation and involve a pelvic floor physiotherapist. You assess the colonic symptoms, and then you assess the gastric symptoms. So defecatory dysfunction is the most common is obstructed defecation. And I won't go into this into detail, but basically it can be mechanical or functional. Patients complain of difficulty evacuating the stool. When it's mild, they'll only notice the problem when it's a hard motion. I can't push it out. I feel like I've left a little bit inside my bottom, or I have to apply perineal pressure in order to evacuate a motion. But the more severe the outlet or the obstructed defecation, the more severe the symptoms change. And so the patients with such a high internal anal sphincter tone, which is not under your control, they will eventually have to have their stools liquefied in order to be evacuated because the obstruction is so severe. But when people come in complaining of diarrhea, nobody thinks the problem is the rectum. And so severe defecatory dysfunction can present as difficulty evacuating emotion, diarrhea, or the high pressure colon can cause pain, cramping, bloating, and distension. It can even mimic gastroparesis because the whole gut is so full that the patient can no longer eat. Or the high pressure annoys the mast cells so that every little bit of food that you eat, it senses its danger and you have severe food intolerances. Then I next look at the colonic function and I assess the bowel habit. Don't ask the patients, are you happy with your bowels or are you constipated? Because nobody knows the definition of constipation. So ask the patient, how often do you pass a motion and what does it look like? And you show them the Bristol stool chart. And the ideal motion is a type 4 motion. So if the patient has constipation or alternating constipation and diarrhea, the underlying pathophysiology is fecal loading. However, if they have just diarrhea and we've ruled out defecatory dysfunction, then how do we distinguish, is it diarrhea caused by fecal loading, as we've just discussed, which is by far the most common scenario, or is it truly fast transit diarrhea, which is mast cell driven? So history is extremely important, and history gives you most of the answers. I don't need to do any investigations as long as they've had their basic bloods and scopes. The history tells me everything. So when it's fecal loading, the volume is going to vary. So the promotions can be small to large. They tend to become progressively looser. The last one can be explosive. The loose motions are loose but remain muddy consistency, and the number of motions can vary. You can skip a day and they can be present from anywhere to 1 to 20 plus. Pain can be severe and excruciating. It can be just before a motion and relieved, or it can be there in the background. It can ramp up before you pass a motion, ease off, but remain there. It can be severe enough to cause vasovagal syncope, which is increased in patients with POTS. And they'll usually be tender, whereas fast transit is large volumes. The volumes tend to remain relatively similar in size, and they tend to be more watery. And the number of motions is fairly stable. So they usually have 4 to 6 or 6 to 8 motions a day. And it's usually more of a discomfort. But you also look at other symptoms. If you see mucus and diarrhea, the patient is fecally loaded. Mucus is the colon's way of trying to lubricate and slide out the hard feces. Bloating will be relieved by diarrhea because you're moving the hard feces that's causing the bloating, whereas bloating and diarrhea is due to mast cell mediated visceral hypersensitivity. And so then you look at the upper GI symptoms. They will, when you have a bad day of diarrhea and you get out all of your feces, the upper GI symptoms will improve. But when you have a good day with your bowels and there's not much diarrhea, your upper GI symptoms will be worse. Dysphagia is more liquids and solids, whereas MCAS, I view eosinophilic esophagitis as the esophageal manifestation of MCAS, but that should have been ruled out on your scopes. Gastroparesis is common because of the fecal loading causing slowing of GI transit, but you can get upper GI symptoms. So how do we treat diarrhea? I don't want to go into this, but basically, if it's driven by fecal loading, remove it. Otherwise, dry the secretions up and stabilise the mast cells. So upper GI symptoms, a lot of people have gastroparesis, and it is the most poorly understood of all of the functional GI symptoms. I don't like the word gastroparesis because in the DGBI cohort, it's not, gastroparesis implies that the stomach's paralysed and never going to work again. It's not paralysed, it's just slowed down in response to what else is going on in the gut. And so if a patient comes in with just one upper GI symptom and it's a functional symptom, so they say I've got reflux or I've just got nausea or I've just lost my appetite, it's usually going to be fecally loaded that's driving it. But if patients have upper GI symptoms, and I think some of these symptoms are being driven by the fecal loading, but I think they're out of proportion. I clear the fecal loading, I see how much of the upper GI symptoms respond, and if the fecal loading has resolved and it's not rebuilding up and the upper GI symptoms persist, then I look at the stomach to see what's causing those upper GI symptoms. We used to call it functional dyspepsia or non-ulcer dyspepsia, which means it feels like you've got an ulcer, but we don't. And it's irritable stomach if you like. And it can be mild or severe. I find that the typical scenario is the patient is fecally loaded, and then they usually have one of these 3 triggers for their mast cells, and then it causes pain. But the pain can be so severe and debilitating that people think they've perforated an ulcer, or they go looking for a median arcuate ligament syndrome. And I usually treat the fecal loading and add in famotidine, which is not only it's a histamine 2 blocker, but it reduces acid. So if there's any acid component, it's going to help, but it blocks the histamine number 2 receptor in the gut. Now, vascular compression syndromes are where a blood vessel is squashing something else or being squashed, and they're highly prevalent in this cohort of patients. and they're usually multiple and all throughout the body. But remember, the presence of a vascular compression does not imply that it's symptomatic. So the ones that we see in the abdomen are the median arcuate ligament syndrome, the superior mesenteric artery syndrome, left renal vein compression, and left common iliac vein compression. Now, these vascular compression syndromes are not usually symptomatic in the traditional sense of the word. So left renal vein compression should usually cause left flank pain and hematuria, but they're not causing typical symptoms, so people think they're not causing symptoms. They are, just not how you think. So if you squash your left renal vein or your left common iliac vein when you stand up, you reduce venous return to the heart. You compromise or drive the underlying issue with POTS, which is reduced venous return to the heart. So they are causing symptoms, but not in the traditional way. So generally, I've realised that SMA is very common. I can see it in 60, 70% of patients that walk in off the street with variable symptoms as an open access scope. So SMA syndrome very rarely causes an acute obstruction. It causes other issues, which I don't have time to go into, but very rarely. So it's more the MALS that's the issue. And so I think in order for a MALS to become symptomatic, you need two prerequisites. You need compression of the celiac ganglion. It's not it's not the artery, it's the ganglion, so it's a neurogenic pain. But you also need to have triggered mast cell mediated upper gut visceral hypersensitivity, because you can have a severe asymptomatic MALS and present like a MALS, present with no symptoms, or you can have severe symptoms that sound like a MALS and no MALS because you've got gastric mediated visceral hypersensitivity. So a MALS needs both. And the actual typical or classic presentation for MALS is just pain. And so functional dyspepsia under the new Rome 4 classification for IBS has been reclassified into two just as equally fantastic names: epigastric pain syndrome and postprandial distress syndrome. And like all DGBIs, we feel that if we just simply name the symptoms, it'll magically fix all of our issues, and then we can just tell the patient they're anxious and give them some antidepressants and all of their symptoms will go away. So epigastric pain syndrome is undiagnosed MALS. So the patients present with epigastric pain that's severe and excruciating. And initially, in the first stages of the diseases, they only complain of this when they're eating or if they're exercising. But as it progresses, the pain will become constant. It's there all the time, but it'll have exacerbations after eating or after exercising. And it can lead to significant weight loss because the patients are terrified of eating because of the severity of the pain, and they would rather starve to death than eat. And so it's often misdiagnosed as ARFID or anorexia. And my theory is because I think that pretty much 95% of my patients with MALS have autism and ADHD. And we know, and then again, predominantly women, and we know that autistic women are fantastic at masking. And so they come in complaining of severe pain, and they don't look like they're in pain, so they must have an eating disorder. The other one is postprandial distress syndrome. And so this is where you get those previous symptoms we just discussed, plus you have symptoms of gastroparesis. You can sometimes see the gastroparesis if there's the fecal loading, which is slowing down the gastric emptying. But generally, they investigate, there's nothing wrong on the gastric emptying study. All the tests are normal, so it must be functional. So this is where, in conjunction to the pain, they also have symptoms of loss of appetite, early satiety, and postprandial fullness, upper abdominal bloating, and nausea. Vomiting is very rare unless the pain is so severe. That's what's causing the vomiting. And
Dr.
this, yes,
Just a 2-minute warning.
okay. Yes, I've got 1 or 2 slides, sorry. So this is caused by lack of gastric accommodation, where the top of the stomach doesn't stretch to allow the food. So as soon as you eat any food, it fills up, you feel full. And then if you've also triggered your mast cell mediated visceral hypersensitivity in the stomach, when you fill up that tiny little pouch because it won't stretch, it's going to hurt. Treatment of that is difficult. But gastroparesis, I'll quickly finish, is those symptoms. Typically, it should be worse with solids, dinner, high fiber and high fat. But regardless of whether the stomach is paralyzed or not, we treat it the same. Stop the drugs that are exacerbating it. Don't use ondansetron because fecal loading is the most common cause of slowing of gastric emptying, and ondansetron slows down colonic function and fecal loading. Treat the POTS, because if you are severely hypovolemic, when you stand up in the morning, you can be nauseous or vomit from being upright, and that complicates the picture. Remove the fecal loading because it's the most common cause of gastroparesis, and prucalopride will make the stomach and the bowel move. Last few things, symptoms pointing to another etiology. If pain is predominant, think of MOWS. If the symptoms improve when the patient lays down and on their right-hand side and their gastroparesis improves, think of gastroptosis, which is where the stomach drops into the pelvis and can't empty. And rapid gastric emptying, which occurs in a subset of patients with POTS, can actually be the cause of gastroparesis. And this is typically nausea that starts half an hour after eating and is wrong for gastroparesis. It's worse with liquids, it's worse with carbs, and it'll be associated with one of these three symptoms: postprandial worsening of POTS, reactive hypos 1 to 4 hours after eating, or insulin resistance that's out of proportional to the BMI. And basically, when you eat, you rapidly dump sugar into the duodenum, the sugar goes high, the body freaks out, paralyzes the stomach, says, don't you move until I have managed to bring the sugar level back down to normal, and then the stomach can start working again. And I won't go through those other things. So rapid gastric emptying can cause delayed gastric emptying. So in summary, functional gut symptoms or IBS is the gut manifestation of POTS and MCAS. And if you don't control the POTS and the MCAS, I will never get on top of the functional gut symptoms, which is why they're so poorly managed. The vast majority of symptoms are driven by POTS. Fecal loading is the great mimicker and by far is the most common underlying pathophysiology that's driving most of the symptoms. Upper GI symptoms can be driven by distal pathology, and so address and treat the rectum, the fecal loading, and if the upper GI symptoms persist, stabilize the mast cells, look for MOWS, and assess or for clinically for rapid gastric emptying. Thank you.
Thank you so much. What a fantastic presentation. We are going to start the panel now. So if all the panelists that are still left with us would like to sign on, that would be great. And I'm just going to introduce the panel. So the title of today's panel is The Reality of Comorbidities and How We Can Better Track, Measure, and Treat Them in Our ME Population. Why we chose the topic was because we felt there's a significant gap in research and clinical care when it comes to understanding comorbidities. And because of that, it's creating confusion and conflation in our data, exclusion of entire groups of patients in research projects, and at times possibly poor results and increased groups of dropout rate. Some of this is predictable if you look at the problem through our lived experience lens. So we wanted to discuss it with all of you to get your thoughts on how we can better track, measure, and treat our comorbidities. And tomorrow we're going to be looking at research design, and this conversation and what we've learned today is going to help influence tomorrow's conversation, which hopefully is going to get us to a place of, so we've learned all this, what are we going to do about it? Because otherwise we'll just keep repeating the same cycles. And I think we're all in the same place of wanting to stop repeating those cycles. So that is why we are having this panel today. And also for those who have to leave, we totally understand. This was such a good opportunity to get content for our research network. It's too good of an opportunity to miss, unfortunately. So we have allowed folks to go a little bit later so that we can get that content and we can share it with our community, not only those who are here live, but for many who can't be with us. So we are going to go through some questions now. Some of them are pre-submitted. I know many of you have answered a lot of the questions in the Q&A box. Thank you so much for that. That gets a lot of extra questions answered. I guess I'll start off with maybe Jamie, because I know that you and I have talked a little bit about comorbidities, and could you summarize for folks why you think that comorbidities are so important in terms of the research and the care aspect? Like, what are we missing and what can we be doing better?
Absolutely. So I think it was Todd who was mentioning, for example, that when people are running POT studies, they may not be looking for PEM. And we need to be aware of the enormous overlap of ME and not just POTS, but dysautonomia in general, because the way that we treat these two diseases differs. And it's not just an ethical consideration, although of course it is that. It's whether you want to perform a credible, reliable study or whether that doesn't matter very much to you. If you are testing whether recumbent exercise is useful in POTS, including people with ME will mess up your data unless you deliberately obscure harms or don't bother measuring them. In addition, when we talk about the overlap between POTS, ME, MCAS, HEDS, fibro, and all of these other IACCs, and potentially neurodivergence as well, what we use to treat these different disorders and how we diagnose them needs to be considered together. For example, people with neurodivergence tend to have higher levels of serotonin in the central nervous system. And that obviously affects things like MCAS and how that might present. So that will affect disease management considerations. Very general statements, but hopefully we can pause there.
For sure. And Dr. Yelman, I know that you're doing this every day. You're treating comorbidities, and that's part, I think, of what the Bateman Horn does. The Bateman Horn Center does so well is it really thinks about what's driving the symptoms, and you guys are like puzzle solvers in so many ways. You're like piecing things apart. So do you want to talk a little bit about your strategy as a clinician and maybe, offer some inspiration to our clinicians here in Canada who may be a little newer to this?
Yeah, I can certainly touch on it. I wouldn't claim that it's easy for sure, but I think we're continuing to recognize the impact that comorbidities and anatomical perturbations and sort of even just dynamic changes that occur when you're upright versus when you're laying down, when your head is rotated versus up, when you're at altitude, when there's a barometric pressure change. Looking for all of those details is really critical ultimately to helping improve patient symptoms in a lot of people. And so we do spend a lot of time trying to identify everything that can be contributing to symptoms. And then I think that's where as we call it, the art of medicine comes in, where you try to figure out, okay, they're having all of these symptoms. What seems to be driving the car here? And it's often very different. And I had that diagram in my presentation earlier that had sympathetic overdrive and MCAS and POTS. I mean, you could expand that with all of the comorbidities, honestly, but it's really interesting how if you get stuck trying to treat one and you're following protocols or you're using everything that you have at your exposure and you can't get something to budge, there's often something upstream of that. Maybe neuroanatomically or vascular pathology, or there is some other comorbid symptom that is driving that, right? So is the reason you can't treat the POTS because there's rip-roaring mast cell, or vice versa? Can you not get the mast cell controlled until you've controlled the abnormal hemodynamic behavior of the POTS? And then it can go down a whole rabbit hole. So it gets more and more complicated. My notes get longer and longer every day. But I think that the more we understand this and the more we look for these complex interactions, the better outcomes we start to see for people.
For sure. And as a patient, I know it makes a huge difference because here in Canada, the way that patients are or used to be treated was sort of looking at it through this very narrow lens. And some of us have had to go to the United States and meet with clinicians who have been in this space for longer to get some guidance to get us started on the right track. Now, some of the clinicians in Canada, I think, are taking more of an interest. They're seeing some of those connections, and we're really excited about that. But we need more conversations, more supports, more conversations. And also, we need to see the differences in the research, going back to what Jamie said. Because if we can't show them how things are impacting one another, then I think a lot of them are going to remain scared to treat. It feels risky to them, I think, to be trying to deal with multiple things at once when they're not sure how that all interacts and what this medication does here. I get a lot of answers from clinicians that sort of say, ooh, you're complex. Ooh, yeah, we're not sure what we can do with you that wouldn't cause more problems, so we'll do nothing. So I think that's too common of an answer, and I think this conference in part is hoping to tackle that discussion.
I think it's important too in this discussion to think about the dichotomy between PEM and non-PEM, right? If PEM really is this altered physiological state where you have new symptoms and worsened symptoms, do assessments of symptoms or assessments of treatments in the context of PEM mean anything? Or do you have to assess those things in baseline functional impairment to actually see a response? You know, when somebody's symptoms are exacerbated, as a clinician, we are always asking ourselves, is this a manifestation of post-exertional malaise? Is someone caught in a metabolic trap here? Or is there something else that has changed in their environment, something with a med, they caught an infection, et cetera, et cetera. There's a barometric pressure change, whatever that variable is, or is it both? And that is also hard. But forgetting that and not treating for PEM and not getting that stabilized first and trying to figure out all this complex web of interactions, I think is not generally successful unless you have first kind of figured out how to break that cycle of PEM to the best of your ability, or at least recognize it.
Yeah, and that brings up another good point too. I think one of the things that we have to think about too is seasonality. We know that there's the October slide, some people call it. I like to call it the fall slump because mine can come anywhere from August onwards. And then the spring bump. So also we see a lot of researchers when they're researching not being mindful of that. And suddenly there's this improvement in the spring. And I always think, well, was that you, or was that the medication or the intervention, or was that the spring bump? And likewise, if somebody gets worse in the fall, was that the medication or the intervention, or was that the fall? And then coming to Beth, I thought the same thing actually as you were doing your presentation when you were talking about the reproductive cycle and how where we are in that cycle as women has such an impact as well. And I thought, my goodness, there's so many factors we need to be thinking of. We almost need all of you to get in a room together, and we need to create almost like a pathway where we just like list all the things we need to be mindful of. And then researchers can sort of have that tool, because it's got to be incredibly difficult as a researcher to come into this space when there's so many factors. So how do we make that easier?
Yeah, with symptoms that fluctuate around the menstrual cycle, to not be asking at the very least where someone is in the menstrual cycle. And per your really insightful comments about weather, this is something we are asking in our clinical study, and we're actually starting analysis based on weather. And what we're seeing is actually different subsets, it seems, respond differently in different weather. So for example, right now, I'm doing a deep dive on patients across illnesses with environmental sensitivities, and they feel worse in winter. Why do they feel worse in winter? Because probably the windows are closed and there's more indoor exposures. And so the weather question kind of also goes back to why it is so important to kind of sub-analyze by less studied pathologies and comorbidities, because there may be interesting trends in symptomatology and fluctuations of these symptoms based on those sub-analysis.
For sure. And Dr. Ryan, you did such a fantastic job of talking to us about all of these things in your presentation. Thank you so much for connecting dots that I have personally for years wanted connected. And I know I'm not alone. There's many in our community who are struggling with these things, these conditions, these undiagnosed problems and symptoms that sort of don't seem like they're connected. And watching that presentation, I just thought, check, 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 check. There's so many things our community, I think, is going to be able to connect dots on. How did you start to see and figure out that, like, where did POTS come in for you into this equation? And how did you start to learn about MCAS? Like, and how do we get your colleagues to start thinking this way?
That's harder, the second part. Really because of COVID. So before COVID, I'd heard of POTS, I'd never heard of MCAS, and but I'd always thought that irritable bowel wasn't that hard to manage, but I only saw the mild end of the spectrum. And then when COVID hit, we had a late hit where I live. It didn't come to sort of December 2022. I suddenly noticed that all my IBS patients were complaining of all these other weird symptoms. So they would walk to the couch and their Apple Watch would say 150. And I'd say, why's your Apple Watch 150? You just walk to the couch. Oh, I've been getting palpitations. And I used to see 5% of my cohort of IBS would say, I get brain fog after I eat. And I'd say, I'm sorry, I don't know what that is. I can get your gut better, but I can't make your brain better. And now I realize that's postprandial worsening of POTS. But unless the patient brings it up, we don't ask for palpitations. And so I started routinely, I ended up finding a group of like-minded colleagues where I'm based who manage long COVID, ME, POTS, MCAS, and as one of the only gastroenterologists in the group with open books, they sent me all of their complex patients. And so these were patients that had seen 3 or 4 or 5 other gastros and had no answers. And so the learning curve became extremely steep. And I mean, these are desperate patients. They'll try anything. So you'd say, well, let's give this a go. And they'd say, okay. And it works. It's like, okay, well, it worked for you. Let's see if it works for the next patient. And it was just exposure to so many sick patients and a steep learning curve, and listening to the patients saying, this works for me. Well, I don't understand that. And so if I have a symptom that I don't understand, it's like, well, it's either going to be a POT symptom, an MCAS symptom, or is it a connective tissue issue causing the symptom, or is it a mixture of all? And that's how I approach pretty much any body symptom for these patients. What's the underlying cause of that symptom? And sometimes a mast cell trigger will cause a POT symptom, or a POTS trigger will cause a mast cell symptom. And it's figuring out, if something happens, why does it happen? Because I don't need to know the underlying molecular basis, but I need to know this trigger is causing the mast cells to be angry, or the hyperadrenergic state to worsen, and then it's causing the gut to slow down, or the mast cells to activate, and just from there it's sort of built.
Wow.
But I can't get my colleagues to take me seriously either, so.
Well, we have to do more around that, I think, because this is a massive problem. And sometimes when I think of the people we've lost with ME, who have had serious digestive issues and have not made it and have suffered excruciatingly. I just think this is part of what we need to know, right? This is part of what we need to learn. This is part of what we need to treat. This is part of what we need to research. And it's life-saving in our community, I think, to be able to understand these issues more effectively, because we don't have enough Bateman Horne centers. You know, we would need one in every corner.
But I've also realized that with the feeding tubes, when I first started working in this area, I didn't understand the importance of the POTS and the fecal loading. And so I was inserting a lot more post-pyloric feeding tubes. Whereas now I have a network of colleagues that make managing these patients a lot easier. But I now intervene with aggressive IV fluids early. So if I have someone that comes in and they're passing a motion once every 3 weeks, they're not going to respond without fluids. And so I will just I moved my practice to the top of an emergency department. So I'll give them 2 litres of fluid on the way out, just to kickstart the rehydration of the feces. And if their bowels don't work with osmotic laxatives and they can't get the salt and water in, I just give them fluids. I give them 2 litres of saline a week until their bowels move. And I have patients that, when they have the fluids, they go every day. If they drop the fluids down to fortnightly, they start going once a week again, and nothing else has changed. And it's simply the severe hypovolemia that's dragging the fluid out. But once the fecal loading rises, it drives the POTS and it drives the MCAS, and then it's just a vicious cycle after vicious cycle. So IV fluids are incredible treatment, but there's just a huge reluctance to use them. I mean, I have about 15 girls with ports or PICC lines, mainly ports in, but the reluctance to give fluids in these patients, I don't understand it when it can make all the difference.
As somebody who's had to fight very hard for IV fluids and then lost them, I completely agree. So it's something we need to do more with, and I can see a giant shift in my body in so many ways, with the fluids and without the fluids. One of our questions that came from one of our younger researchers, who's one of our Stars of Tomorrow poster presentations from earlier today, asked a really good question earlier around comorbidities and research, which is, you know, what's the suggestion in terms of like how to do that well? And the question was something along the lines, and I'm sure I'm going to get it wrong, but it was something along the lines of, do we just ask people? Do we use surveys? Or are we expecting doctors to diagnose them? And obviously we know that we don't have enough knowledgeable doctors who are going to diagnose a lot of these things. So that's probably, I mean, as a patient, I guess I would see that as being a really tough option, because while it certainly helps in the research, it's almost impossible for patients to get properly diagnosed. So it would keep us out of the research completely. So what are some ways that we could perhaps, do a better job. I gave the example of the NASA lean test for POTS because that's a really objective one that's easy to do. But what are some other ways in which we can start to move in the right direction by adding measurement into the research in ways that maybe are doable?
Yeah. So this is a huge part of my job where I collaborate on multiple clinical studies and bring in a less studied pathologies perspective and screening for comorbidities into these studies as well as clinical trials. And there are multiple ways to do this, and really depending on study design, it can change. So one of the ways you do this is you ask a very comprehensive medical history survey. Some of these can be 30, 40 plus pages and have to be filled out, bit by bit, but that's really important that both covers symptoms as well as prior diagnosis. However, that's obviously not enough given the chronic underdiagnoses of these illnesses. So another thing we can do is there are many instruments that can be used for research testing that can evaluate for the comorbidities that we've discussed today. So for example, for POTS, there's COMPASS 31 or the Malmo-POTS symptom score. For ME/CFS, we have 5 different types of diagnostic criteria. For functional capacity, we have FUNCAP or Bell-CFIDS. For mast cell activation syndrome, there's a lot of controversy about what are the best instruments for that. For HEDS, we have the 2017 criteria. We can do Baton score, and I can go on and on and on. And this is discussed a bit in my paper with PLRC on optimizing clinical trial design for long COVID. And the other thing you can do is you can incorporate assessments into clinical studies. So our clinical study at MIT, we assess for hypermobility, and we do a NASA lean test, though I would prefer the 10-minute stand test, active stand test for POTS, while also tracking, blood flow and capillaroscopy and other measures. What I'm most excited about is the emergence of biosensors and the emergence of wearables that actually help with tracking for at-home studies so that we can include the most severe patients in these studies, and we can track longitudinally and in real conditions without needing to bring them into the lab. But yes, I would say a combination of in-person assessments if your study design allows, all of the validated instruments, and honestly, some of the instruments that the NIH even recommends for ME/CFS haven't been validated yet, but are still excellent. And then a really comprehensive medical history survey of symptoms and diagnoses in combination, if you're sufficiently powered, can really provide excellent data for analysis.
Fantastic. Anybody else want to add to that?
I would second everything that was said there, and I've sort of wondered about whether we could create a national or international repository that patients who have received a diagnosis of ME/CFS or long COVID or et cetera, ME symptoms could actually get into, or they could fill these things out on their own time, maybe even over the course of a year, because it may take that long to get through it, but that it's all there somewhere accessible to people who are designing these studies, right? Even for these tools that are not validated yet, maybe they will be, maybe we will end up using those tools later. I don't know how we get to that point, but I would love to see someone wrangle all of us up to create something like that, because you can't just bring somebody in on their first study visit and expect them to be able to complete all of this work. That's been a challenge for people, unfortunately.
Well, and actually, that's one of the things we often talk to researchers about is breaking things up into smaller doses, because when they are trying to do the job well, there's so much that can come at a patient so quickly that it actually reduces the patients that can participate to the very mild patients. And again, using the term mild, I hate the term mild. There's nothing mild about 50% reduction of function. But it ends up with a false representation of the spectrum that we're trying to study. And I think we have to be cautious while we want to add to the research. And I'm certainly encouraging all of us to think about how we can add. It's also important to break those things up, as you're talking about, into smaller steps, making it more manageable. And like you said, maybe putting something somewhere accessible so that it can be done on people's, own time. They can manage that a little bit themselves. And don't promise me a good time with bringing everybody together and trying to build consensus, because I just might do it.
The other things I would add to that, I do think it is really important for anybody in the research space who wants to design a clinical study to spend time consulting with physicians or other providers who have done this their whole career. Just the way that we've seen things interact or things get thrown off when we're trying to treat or assess for one thing by another comorbidity is something that I think really only clinical experience can inform to the level we need to understand it. And we should be involved in study design and talking about those pitfalls before we even design the study. I think that's going to lead to better outcomes. I think PEM screening, I know there's a new tool out from Leonard Jason, really thinking about how we improve that kind of screening and that assessment in research studies is going to help us. We need to be looking at whether someone's in PEM or not. When we look at adverse outcomes or bad reactions, et cetera, we need to be thinking about whether bad reactions could be mast cell mediated or if they're actually the drug or the intervention. We need to be able to differentiate those things. And I would say lastly, just on a very basic level, I think many of us in this space are really, while we can get really granular and complicated on how to really manage any individual patient, I think we still need to demand better on average for all the people suffering from ME. We just need more diagnoses. We need more counseling on PEM. We need more validation and very basic interventions for orthostatic intolerance. And while that won't be sufficient to help people get completely better, more diagnoses, more people in the space, more clinicians who understand some degree of the illness and believe in it, you're going to start seeing this critical mass build up over time where we really do have more people in the space and more resources at our disposal to fuel the kind of studies we really need.
Yeah, and I just want to mention some resources in case they're helpful for people. So one is the NIH Common Data Elements, or CDE. They list instruments that can be helpful for research on ME/CFS. As part of PLRC, we funded $5 million in clinical studies and research on long COVID, and we required everyone we funded to screen for comorbidities. I wish we also required sub-analysis and, being sufficiently powered for some of this, but we required that, and that is out there. Also, read clinical study protocols. Our clinical studies are becoming more and more advanced. There are some coming out that haven't been published yet that I'm really excited, that are very complex and nuanced. And I want to echo the point that we absolutely need patients involved at every step of the way, from the very beginning, from conceptualization to study design, and also clinicians and scientists and community members. There are committees in our field that involve very few people who have helped design studies on long COVID or ME/CFS, making really important decisions. And it's critical to have, the right balance of enough people from each group, that all of these interests and all of this very specialist expertise are represented. And yeah, I can't say enough about how important that is, but we're also all overstretched and we can only volunteer so much. But it is very important every step of the way to have each group of expertise part of it.
Yeah, and I mean, obviously we agree, lived experience is very, very important to ICAN-CME. And I think we are trying to model that within this conference, but also within other things that we're doing with the researchers we're working with. And so to shift focus a little bit to some of the folks that we have on our panel who are living these experiences, I would like to hear from Ruhi and Sammy. If new people are coming into this space, first of all, new people are coming into the space, they're having a lot to learn quite quickly. So people always ask me sort of, if they're new, what's the first thing I should do? And I always say, first of all, make sure you're taking care of yourself and your family and taking care of your own needs first and learning what you can about this illness. And then they want to get into advocacy, and it's not an easy space to get into. Research is not an easy place to be in. A lot of systemic barriers still very present. It's hard sometimes to be the person in the room who they're talking about, but not to. So I'm sure you guys have that experience as well. So I guess from your perspective, first, maybe as moms, what would you say to parents who are coming into this experience for the first time? Where do they start? What are the first 2 or 3 things you would suggest they do? Either of you can go first.
No, Sammy, you go. I think it's a very challenging question, actually, to answer, because each experience is very, very different. Sammy's experience is very different from my experience, because I was coming in with a lens of, already having science and medicine and all of that in the background. But Sabrina, you and I have had this conversation, and I've had this conversation with Jamie too, that regardless of having all of that in your background, the impact, the traumatic impact of like somebody going suddenly from being very healthy and active and engaged to in a dark space, unable to move, unable to vocalize, is traumatizing beyond like it's difficult to articulate. It's a profound sense of disembodiment. It really is, and it takes a little while to come back to yourself. And I think I would like to say that it's to really appreciate that. Like you have to say that this is acknowledge that this is an incredibly challenging space to be in, and this is a very traumatizing space to be in. Like rather than just going like being very strong and going at it, just take that space and acknowledge that space, because you have to be very emotionally present for this person. You really, really do. And you have to be able to separate your emotions and your grief from impacting the care that you're also giving to them. And I don't know, I think that's why I'm bringing up the ethics of care model and really want to work within that space to figure out what is the praxis of that. Not just theory, because in theory we can talk about it all the time, but how do we model it in real life and not standardize it, because you can't. I mean, Braden knows this, and Jamie knows this, and Beth knows this. You can't standardize it. Each person is going to come with various different manifestations, and therefore I think this is really something I'm working on at this moment, how to do that. Sammy,
Awesome.
please, I want to
Okay.
hear what you have to say.
Thanks. So I would also agree, like take a deep breath, first of all, because this is an endurance challenge, not a sprint. And although we want the information immediately, and now, yesterday even, actually there's a lot of information to process. And one of the mistakes I made early on was to think that once I had learned some information, I could fast track other people's experiences by sharing that information in what I thought would be a helpful way. And although it was helpful to have it, was also overwhelming to receive it all in one go. And it took me time to understand as a patient advocate that I couldn't fast track someone else's experience. They need to go through it at the same speed and digest and process and learn. So that's been a big learning experience for me, but also to understand that we have to advocate for our children and be their voice at a time where they can't use their own voice, and trying to always put them center rather than, as you were just saying, rather than imprinting your own grief, trauma experiences onto the way that you advocate. So that's also something that I have been learning over the last 5 years, that it isn't just about me imparting what I think is right or what my family has experienced, or that even the broader families within our support group have experienced, but actually making sure that we connect directly with the young people who are having those experiences and representing them authentically in the best way that we can. So my advice would be connect with peer support groups where you can dip in and out and take the information in digestible bite-sized chunks, But make sure that you're in a support group that's well moderated, that's providing reliable information, that isn't allowing the sharing of misinformation or unvalidated therapeutics, etc. And find your people and stick with them.
Wonderful. That's really helpful advice and information. Jamie, I want to ask you, one of the questions that we got actually in our support group was how can we better educate and alert autistic folks that their autistic burnout might actually be ME and that it's something to take seriously. And I just thought if you had any thoughts or if anyone else has any thoughts, but that does come up a fair amount in our support group as people are sort of trying to figure out what's this cause of this experience I'm having. And sometimes when there's multiple things in the mix, it can delay sort of, if they are ME patients, it can certainly delay kind of that part of the puzzle for them because, you know, doctors will focus on the thing that's most obvious in front of them, I think sometimes. So is there anything we can do? Can we better educate?
It's a good question. And I think that this is where the phenomenological experience comes into play. People who have both neurodivergence and ME could probably tell you the difference between post-exertional malaise and autistic burnout because they present differently and they feel different. But it's very rare that you'll see them directly compared to each other in people who have both sets of experiences. And in fact, I've even seen some autistic groups adopt post exertional malaise, beginning to say that that is autistic burnout. Now, I don't believe that it's been researched enough for me to be definitive one way or the other. But I will say, from what I hear from people who have had both experiences, they're really different from each other. They feel different. They present with different symptomatic experiences. I think, in terms of reaching out to people who are neurodivergent, and by that I mean autism, ADD, ADHD in this context, we need to get out there on social media where people who have those lived experiences are sharing information about their lives and communicate that in a very direct way. Um, Getting things out into the literature is always good, the scientific literature as well, because then it gives people a framework that they can use. And at the same time, I'm not sure we're really ready to publish something so definitive about how different they are and the ways in which they're different. I think that that's its own study.
That's a fair response. I think the folks that we have in our community who have had autism or ADHD, pre-existing ME, they're very clear about where the two they seem to feel very clear. I think it's when sometimes everything is getting diagnosed and kind of coming on all at the same time, they're never quite sure which one is which. And we don't really know kind of how to guide them because there aren't a lot of safe people to send them to even be able to really suss
Yes.
out one part of that, much less both.
And I would also say that I've noticed this. I am neurodivergent. Hello, everybody. So I have noticed that when my ME symptoms are minor, cognitively speaking, and my ADHD symptoms are severe, cognitively speaking, they do kind of meet in the middle in some ways. However, the extreme experience of ADHD, the extreme experience of having a crash in ME, these feel very different to me. But yes, I will say that there's some crossover in the brain fog, distractibility, fatigue leading to increased sensory sensitivity domains, like we talked about in the study that I was discussing. And I do really think that if we're going to talk about how we characterize these things, the enormous number of people with ME who are neurodivergent, um, and how many of us are represented in research are a really good place to start communicating the similarities and differences in terms of symptomatic overlap and the increased prevalence between these two conditions, sets of conditions.
And I love the way you explained earlier neurodivergence, by the way, just a shout out to you. I thought that was so beautifully done. And I think I'm really excited to see where you go with this research, because I think it's important. I think it's an important part of the conversation, and I think it needs to be done by people with lived experience and people with respect and care. It needs to be handled thoughtfully. Like everything in our community that should be handled thoughtfully, this is another area that I think really needs to be handled thoughtfully.
Yes, and two groups of people who have experienced a lot of misunderstanding in the sort of biomedical framework of illness and the way it treats people with long-term issues that may be complex and challenging to understand. So both communities have faced a lot of dismissal and a lot of gaslighting. So it's really important that people with lived experience have shaped this work. And I will add, in addition to that, I'm deeply embedded in the ME community and less so in the neurodivergence community. So I have pre-asked a number of researchers whose work I trust in the neurodivergence field if they would be willing to look over my work and make sure that when we're publishing, we're not saying anything that that community would find offensive. As an advocate in that area, I know what I personally like and don't like, and that's not the same, as we all must acknowledge, that's not the same as really understanding how the community as a whole feels. You have to go into advocacy for that.
Excellent. Yeah. And I mean, I see it all the time in our community where people are really well intentioned. They want to create resources and supports, and, they're doing great work with great heart, and we're so grateful for them. But sometimes one or two things can make it kind of go sideways. And I think the patient perspective is there. Like, yeah, we're tired, we're sick, but we're pretty good about jumping into a project if it means that our community will benefit. There's lots of us, and we're happy to get involved. So it's just a question of like asking and sharing, and we're there. One of the communities that we don't have in our community yet, and one of the comorbidities that we don't talk about a lot, and I think of it especially in relation to children and teens, young people, is PANS PANDAS. I have a loved one who I won't name or give too much away on, because that's their story to share, not mine. But PANS PANDAS is something that I think is often misdiagnosed as mental health condition. And I think it's something that we need to bring into our community and kind of have an understanding of. And I've started asking more questions in our community, and it turns out a lot of individuals in our community actually have loved ones with this diagnosis or believe that they may have that diagnosis. So there does seem to be some crossover. And then, of course, it's an infection-associated chronic disease as well, or chronic illness. So I guess one of my questions to you guys is, are you seeing some talk about this kind of stuff? And if not, what could we be doing better to bring that community in? Because that community has also been traumatized and gaslit in a really significant way. Some families are so traumatized that they can barely recover from it. So I think there's a lot of fear there about connecting with another community, but I think we understand what it looks like and what it feels like. So we could reach out and we could bring them in and we could learn from them, just like we learned from long COVID, just like we learned from MCAS and POTS, and, whether everybody has those diagnoses or whether it's a condition that's under that umbrella and we can learn from them. I think it's really important to do that. So are you guys hearing about PANS PANDAS? And could somebody define what that is for the people listening? Because if I have to try and remember what PANS and PANDAS stands for right now, I'm going to not do a good job. So
I can grab this. It's a pediatric neuropsych disorder that was originally just considered to be post-strep, but then expanded to be considered post a wide variety of infections. Often shows up with tics, obsessive compulsive disorder, night terrors, new fears in children. And yes, one of my cousins was diagnosed with PANS PANDAS because IACC's run in my family like nobody's business, I suppose. It is often treated successfully with antimicrobials, like a regular, if long term, course of antibiotics. If that fails, often with IVIG. And there is a clinician at Stanford, and I was trying to remember her name, who her focus is PANS PANDAS, and she often speaks at the it's Jennifer Frankovich. That's who it is. She's often spoken at the MECFS conference that Stanford runs once a year. So I think that there's potential to draw that community in. I think it's an IACC. I think that we don't have a lot of crossover with pediatric, and it's a good idea if we were to do so.
Yeah, and I think one of the things that I noticed when I was working on a project a couple of years ago was our exclusion criteria for the Canadian consensus criteria, I think it is. One of the exclusion criteria is eating disorders. And I just thought how many kids with PANS pandas, how many families with PANS pandas have been diagnosed with an eating disorder when in fact they don't have an eating disorder. They have MCAS or they have something else at play that once treated or managed, suddenly they enjoy food again. I'm an adult who's struggling with that myself, so I totally get it. But I imagine there's a lot of families getting excluded out of research because of the exclusion criteria. So I'm also a big believer we need to update our criteria. The Canadian consensus criteria was 2003. I know I'm just throwing stuff out here. Jamie's like, I've heard this before, but like, I really believe one of the things we need to do is update our consensus criteria. We've had in 2015, we had the IOM, which was, fantastic. And I think is clinically really helpful and is certainly a second option that a lot of researchers will use. But before that, it was Canadian consensus in 2003. I can't remember what year the international consensus criteria is, but it's time to bring everybody together under one roof and like get some of this stuff updated with all the knowledge that you all have. It's all in your heads and we don't have it on paper. And I think it makes it almost impossible as we think about, there's a term in business and it's escaping me because I'm too tired now. But there's a term about,
Minimum viable product. Do
no,
you
it's when
mean no?
no, it's when you're trying to plan sustainability. You're trying to plan
Ah,
sort of the next generation of like how the business is going to run and you have all the tools and resources. And I think sometimes I wonder about some of the people that are going to retire in our community and the knowledge that they hold, the knowledge they possess, the trials and tribulations that they've had, the way that they've tried things and they've never had a chance because they've been working with an under-resourced space to publish half of what they know. So like, how are we making sure that we don't lose that knowledge for the next generation? And how do we make sure that all of you that are in this current generation of experts are making sure that we're bringing the next generation in as well? Because we have to do that really well. So I think there's just some really big questions around how we're doing that and how we're reaching out. And I think it's not something we can fix until we get in, it doesn't have to be one physical space, but maybe it's a different conference where we just tackle some of these things, but they have to get tackled because we are due to have these things updated and we are due to have the kinds of conversations where young researchers can come in and we can start to impart some of that knowledge and wisdom. And I also think the patient community and the caregivers, the patients themselves and their caregivers, there's so much learned there too that we've never published and we've never put out into the world. And I'm seeing lots of emojis, so I don't think I'm alone in feeling that there's a lot more work we could be doing there. Thoughts?
research in the US is imperiled
Yes.
and we need help rather before we take on an effort that takes a lot of funding, a lot of time, a lot of energy. That's just something we need to consider. And regardless of your politics, the amount of funding that is going to the NIH has dropped significantly, and that is going to have an effect on research today, and is going to have ripple effects and effects on research produced in the U.S. for a very long time to come. So if we were to do something like that, we would need to consider where the funding was coming from. I know that a lot of us on this call and a lot of people listening too have put in so much labor into this research field. As patients, they've given samples, they've given their time, their energy. All of us in the research field have done things for free. Um, we've started to accept that is kind of just the landscape, and it's just the way that things are when this disease is so underfunded. It's just the state of things. But at the same time, um, when we're planning a big project that's going to pull in a lot of people, we have to know how we're going to compensate those people fairly, including people with lived experience who may not have research background, but we want them to talk about their experiences. Severe ME gets left out all the time. Even if we had somebody pre-record a message that they felt like they could share when they're doing their best for them, and that we could play later, like all of those things, they can't come for free because it's disrespectful to the people who put their time and energy. Um, it's not really about money. It's about respectfulness.
Yeah, you won't get any argument here. We're big on that. We definitely believe in.
I know. I've had this conversation with almost everyone on the call at some point or another. We know the environment that we're in, and it's just something that we have to take into account and consider the creative ways that we can find together to engage in broad scale collaborative projects.
Agreed.
I'll also say,
I was
I
just going to say, I just want to make a plug for Canada. Canada's here. We'd be happy to have any of you. Please come. We need doctors. We need researchers. We are just grabbing anyone we can. Just saying, just wanted to put a plug. It's beautiful up here. So carry on. Go ahead, Beth.
we can only really study what gets funded.
Yes.
Even though so many of us work on projects for free, we can only study what gets funded. And so many of us in the field came together for about a year and a half and worked, some of us like part-time jobs for free, to develop the research roadmap. We have a comprehensive roadmap to advance MECFS towards clinical trials, which for the first time ever includes less studied pathologies and takes a comprehensive approach, and it's not funded. And so there's so much we could do, but fundamentally we need more funding. And I'll say, if you kind of go deep into the MECFS literature, there are so many small, retrospective, observational studies that doctors have written about potential treatments, and they're not followed up on. So there's so many interesting findings that just haven't been followed up on. And I know it just kind of comes down to something simple, but I think if we had more research funding, we would be light years ahead. And I think what we have done in this field, like creatively sometimes with such little budget, we have maximized what is possible, time and time and time again, to try to have the most impact. You know, some researchers in other fields may try to kind of do an iteration of previous research to get it published. But really what I see in this field and what I work towards is as impactful as possible on topics and issues that significantly impact patients and that can inform a pathway towards treatment. And that is comprehensive, hard, complex, and expensive research. And it's not just a little iteration. And so we need the funding to kind of match what our approach collectively has been and what we're all trying to do with whatever we have available.
Including sometimes working on a research study for over a year and then having the data set be taken down by the US government.
Yeah, I'm really sorry for everything that's happening to you guys down there. And I just want to say, for the research roadmap, not only are we incredibly grateful to everybody who put their time into that, but we've adopted it at ICAN-CME and we are aligning our funding up to that research roadmap. So we are doing the little bit that we can with what we can here in Canada, but I could cry rivers of gratitude for the work that went into that, from patients, from clinicians, from researchers. I know that it's just an enormous undertaking, and that you all pulled it off so beautifully, and that this document exists that I feel like captures everything we've talked about for the past number of years. It's just beautiful. So kudos to everybody who was involved in that. And just so you know, we appreciated it so much that we've adopted it, and we're going to try and do what we can with it. Ruhi,
And I wish the longer versions were public, by the way. Like we had so much feedback from the public, and we had so many interesting discussions. And you know, the original chapters and the original sections that we wrote for each section were so much longer than what originally got in the final bit. So I wish that could also be released. I don't know, but it would be great.
Ruhi?
I actually wanted to agree with Jamie, and I'm agreeing with Beth. And I'm thinking that it's it's such a massive undertaking because I'm looking at it from a perspective of very severe ME. I mean, very severe ME, completely, absolutely invisible on every front because you're literally in the dark. And I don't want to, you're providing care in the dark. You're trying to manage care in the dark. You're trying to figure out what the next steps are in the dark. So how do we go about, dealing with those issues? And secondly, I do think that entire research in terms of the roadmap, the entirety of it should be available, because that would provide us with deeper insights as well as we move further into it. And I'm so sorry, Jamie, and everybody in these states as to what is happening, especially I'm heartbroken at how the science and medicine is being treated and how women are being treated. I'm furious. I am so mad at this particular point. So we're with you in every which way possible. So I hope we move forward in phenomenal ways. Thank you so much.
I want to give everybody a chance to, I agree, Ruhi, Canada is very much with you. We realize it's your government's decisions and that it's not the people that have chosen some of the decisions that are kind of coming at Canada. It is heartbreaking every time you turn on the TV or you go on social media to see the suffering, the way people are being treated. It's just, and I think, we have to be careful in Canada to never get too far away from the realization that we could fall to the same fate with just one bad election. So we are watching very carefully. We are, our hearts are there, and we're so supportive, and we are so grateful for science, especially in our research network. We are so grateful for science and the science that you've all done off the sides of your desk, and the medicine that you're all doing off the side of your desk, like Dr. Yelman and others. We're so grateful for all of that, and it never is taken for granted. So for us to see you guys in that situation is awful, and I just want to highlight what Ruhi's saying because she's right. I want to give you guys a chance to just any final thoughts, any final words before we go, and again, an acknowledgement that there were so many great questions and we grabbed what we could. But we will never get through all your brilliant questions, group, because we have the most brilliant attendees, I think, ever, and the questions are just amazing. So we have a whole other day tomorrow, and we will get some more questions in tomorrow. And tomorrow, some of the things we've talked about yesterday and today are going to come together to kind of, I'm hoping we're going to really start to be able to put some things down to say, like, these are the areas we want to move forward. And at ICANN-CME, we plan to try and hold some accountability to those things that we're going to decide and look at tomorrow. We're not expecting everybody else to sort of, run off and do everything, but there's a personal accountability, and then there's a little bit of coordination. And I'm really hoping we can help coordinate some future conversations and some future action in some key areas, not only for our Canadian audience, but globally and internationally. We are a collective and we work really closely together. And I think I've said many times today how grateful I am for all of you. Our whole research network is very grateful for the work that came before, for the advocates that came before. I am constantly reminding people that though we are very sick, we have accomplished a lot of very important work. And I'm all for saying it's unfair that we have to do it, but by God, we have to acknowledge the great work that's come and the shoulders that we stand on. Boy, I am honored and privileged every day that I get to stand on those shoulders and do the work that I do. So, I think we'll get to some of that tomorrow as well. So final thoughts from any of you in terms of what we talked about today?
Honored to have been here and honored to be listening to you as well, Sabrina. Your work has been incredible on this and your whole team. Absolutely. And this has been, I've said this on Blue Sky a bunch of times, this has been one of the most interesting conferences because of the wide variety of different kinds of talks. I feel like it's almost perfectly balanced between original research, clinical care, and sociological considerations. And I just want to say to all the speakers today, I enjoyed every single talk. I thought what everyone had to say was so interesting, and the questions have been really good. I hope that this kind of conference continues in a really similar way into the future. So thank you again. That's all.
Thank you, Jamie. I did say earlier to Jamie that I I could die happy. Jamie said something nice about us at on the conference on Blue Sky, and I was like, I can go happily now, because a lot of work went into this. Our whole team has put a year and a half into this. We even wrote the grant for this a year and a half ago. This is no small feat. Our team deserves just massive kudos, and doing that with chronic illness in the equation, I mean, and all the systemic barriers and everything, kudos to our team and to our network for pulling this off.
And to your leadership, Sabrina. Thank you so much to everyone, including you.
Well, thank you. Any other final thoughts?
Yeah. A few things that within the really important scope of comorbidities maybe didn't quite fit, but I just want to put it on the agenda of things to talk about, which is one, we have such a shortage of doctors who are specialists. And I did just some crunching that, at least in the US, if we have 21 specialist clinicians in the ME/CFS Clinician Coalition, that's one expert for every 157,000 people with ME/CFS. For mast cell, they list 33 specialist physicians. For autonomic neurologists, we have about 129 in the US for 3.1 million people with POTS. I could go on. And so as we advance research, is critical, and thank you to Bateman Horn for the med ed you do. It is critical that we increase the number of doctors. And I also just want to say that research takes a really long time. Well done, well thought out research on highly complex patients that does not, exclude the complexity, but includes complex and severe patients. It takes a really long time. And that's if you can write the grant and get the funding. And so in the meantime, there's so much that I think we can do as a community to increase the quality of life for people with chronic illness, from work leave policies to caretaker pay policies. I co-wrote a piece in Harvard Business Review on work accommodations, but I would love to see more of that, because research is going to take a long time. That's if we are fully funded. So what can we do in the meantime? Because so many millions of people are suffering. And also, I just want to say, so many people in this field, clinicians, researchers, they're sick too. I would say a lot of the people who deeply care, not everyone, but they're sick. They might not be public about it, but they're really sick. And so these kinds of policies that can help people maybe stay at work or help people make lives just a little bit better, it allows this whole field to keep going.
So beautifully said. We don't talk about that enough. A lot of our people are also living with chronic illnesses, whether it's ME or adjacent illnesses, and they are not always out publicly with that information, but many of us know behind the scenes how many people are working not only on the side of their desk, but with limited spoons. So yeah, it's really special. It's a really special community that I think I'm so honored that I get to work with all of you and know all of you, truly. And, Dr. Ryan, I know that we're just, I'm hauling you into this space, but we want to keep seeing you. We want to keep working with you. There's so many new people that I feel like we've come across over the last couple of years who are just doing tremendous work. And it's the way you do it. The reason that I wanted to have you here so badly, and I mean, I'm such a fangirl, it's crazy, is that I think I have watched you now for a while. When nobody's watching, I feel like that's where you can really see who somebody is, when nobody's watching. And I feel like, on social media, when you talk about certain issues and you're just talking casually and you're not doing it to try and get an audience, you're not doing it to try and get the right answer, but you just have a way of talking about patients and about care and listening and engaging that's just so genuine. And so, yeah, you're such a treat. And I wish I could find 20 or 30 more people like this to bring in, because Dr. Gelman's tired and, Dr. Bateman are tired, and we need as many new people as we can. And we need expertise. We need expertise in so many different areas, because this is a multi-system illness. So, not only shout out to everybody who's been in the space, but shout out to the new people stepping into it. It's not an easy space to step into.
No, but I think it is rapidly growing. But in Australia, it seems to be led from the bottom up in terms of it's the integrative general practitioners that are leading it rather than the specialists. But I'm lucky to be part of a WhatsApp group of over 200 specialists, GPs, allied health, naturopaths, dietitians, exercise physiologists that just talk about all of these issues and the learning from your colleagues. I've learnt more in 3 years in that group and being in the long COVID world than I have learnt in the last 20 years of medicine. And it's truly enlightening, and it's also extremely disheartening to manage such sick patients that the world forgets and your patients ignore and then try and prevent you from helping. And it is difficult, but it's extremely worthwhile when you can see a sick person and you fix the gut and everything else starts to fall into place as well, because it's a bi-directional communication. You fix the brain, the gut gets better. You fix the gut, the brain gets better. But it doesn't matter what you do, you just got to break those vicious cycles and start to get the patients better. But yes, we do need more of us, because burnout is extremely high in this group of physicians, unfortunately.
Well, thank you for being here with us.
Thank
Dr.
you for having me.
Gelman and Ruhi, I want to give you guys a chance for last words too.
I actually have to go and actually give care. And it's been I'm just profoundly grateful to all of you and for creating spaces for these very interesting and incredibly challenging subjects, and to be able to have a space where we can really explore how we can move forward in a very humane way. I think that's so important. It's so important, period, in the history of humanity at this very particular point, but especially as we're looking at these complex conditions that are so devastating, that it's really critical. How do we move forward in a profoundly humane way that respects all of our humanity, not just a particular population, but all of us? And I think this is a great space, and I think I'm really looking forward to, even in the space that I'm existing, I'm looking forward to having more conversations into this, and then actually be able to form praxis in different ways. So I think this was a great space to come to and have these conversations. I felt fantastic about it. It felt good to have a difficult conversation. I don't know how else to articulate it. So thank you. Thank you so much.
Thank you for being willing to be vulnerable and share so much of what is going on that we don't get to see otherwise, right? If we don't have people like you sharing those stories, we're not seeing it, and we need to see it. Some of us have certainly lived moments of it, but we need to be talking about it more. We need to be expressing it more. We need to be including it more. And so thank you so much for being a part of that and sharing. Dr. Gelman?
Rena, I may be tired, but I'm well caffeinated. I would just remind everybody, or share with everybody, I suppose, that though we talked about some of the challenges that we've been facing, especially when it comes to funding and research, even amidst all of that, I am really excited for where this field is heading and the rate of growth that I've seen in the last 2 years compared to the first 5 or 6 years that I've been in here. I think that we have made tremendous strides in pulling together all kinds of complicated ideas that are interacting. The research roadmap is a great example of that, but I've attended other conferences with basic science researchers, and I've seen the level of the work that's being done go from very granular to seeing the bigger scope. I really think that there's a lot of room to be excited amidst all the challenges.
Well, that's a really good, happy way to end this panel. And I would agree. I would agree. I guess it depends on the day you ask me, but I think there's a lot to be hopeful for. There's a lot of things we didn't touch on today, which were medications that I think are new in the space that are really exciting. Some cancer drugs, GLPs, CRISPR technology. We don't have anybody that we could have talk about that, but there's a lot of really interesting things happening in the space that I think we're just at the beginning of sorting out and figuring it out. So much more. Save it for next year, and we'll talk about all that great stuff again. But thank you guys all for being here with us today, not only for your presentations, but for the panel and being willing to just stay together and be in community and talk. And and for
Thanks for
engaging so
organising.
meaningfully. Yeah, thank you so much. And Dr. Moreau's there because he's our scientific director. So yeah, we want to just thank you guys for today, another wonderful day. And reminder to everybody that the same link should work tomorrow. And tomorrow's our final day together. And I'm becoming more and more reclined as we go through this experience. So I will see you all tomorrow from a laying down position.
Thank you so much.
Thank you
you
so much,
later. Thank
Sabrina,
you.
and planning and organizing committee. Thank you so
Yeah,
much.
definitely. See you later.
Hi,
That
guys.
sounds good.